will be assisting with the logistical support for this Zoom session. To provide comments, please open the chat box, which is located towards the bottom part of your screen. You click on the talk bubble icon and this will pull up the chat box, which will open to the right side of your Zoom interface. Additionally, we ask that you select the speaker view option located at the top right side of your Zoom interface. This will allow you to see the speaker as they present or share information. All phone lines and computer lines have been muted. If you need technical assistance during the session, please type the issue into the chat box and I will work with you to address any issues. Finally, please note that this session is being recorded, and I will now turn it over to Dr. Gettinger.
Good morning. Feel free, Jennifer, to allow my camera to be started. So, and I can have the first slide if that's okay. The next one, please. So welcome everybody. This is the second public session with the identity team at ONC and our outside expert consultants working to respond to the congressional request that was part of the appropriations agreement last December to basically review identity and patient matching and give recommendations back to Congress in the form of a report. In order to do that, we have reviewed the literature and the many, many prior efforts in this space. And we have solicited broad engagement from a variety of stakeholders. We had an incredibly successful June working session. We had a federal working session, and we have today's working session. You will see all day long this website, identity.onc@hhs.gov. We welcome feedback from the interested community, and this topic has been of phenomenal interest to the broader community. We will be taking that feedback through this Friday. We've had it open all summer, so feel free to communicate with us. Jennifer, could I have the next slide? And so in our June session, we had a tremendous number of consultants. Next slide, please. So the slides are a little bit slow coming up, at least on my screen. I'm not sure if others have seen, can see the slide deck a little bit more quickly. But the next two slides just demonstrate how broad the consensus was in that June meeting, how many folks actually spoke. There we go. Finally refreshed on my screen. I hope it refreshed on your screen as well. Could I have the next slide? And so two slides full of people who spoke at our June session. And the next slide, we had a federal session as well. Next slide, please. And you can see all the different departments and agencies in the federal government that have great interest and participation in this initiative. The next slide, please. So with that, it leads to today's session. We have a wonderful and very busy day planned for everybody. We have interspersed both lunch and a couple of breaks, but things will be incredibly fast moving. Could I have the next slide? So here is my contact information. I'm usually pretty easy to find. But right now, again, I want to welcome you to what I expect to have as a great day, and want to identify both the internal ONC team, Beth Quill, Lana Moriarty, and Carmen Smiley, and our three expert identity consultants, Alan Viars, Jeremy Grant, and Dr. Sean Granis. And with that introduction, I am going to turn it over to Carmen, who is going to orchestrate the day on a go-forward basis. Carmen?
Thank you so much, Dr. Gettinger. We're really excited about today. As Dr. Gettinger described, it's a jam-packed day. It's an all-day long session. We encourage everybody to listen in as you're able. There will be a recording of the session on the ONC Patient Identity and Matching website later. There will not be slides available, however, and I do want to point out that there will not also be a traditional question and answer session available. We do encourage people to add comments and other input into the chat. And as Dr. Gettinger also mentioned, we encourage you to send formal input or more detailed input to the identity.onc@hhs.gov email address. We've had lots and lots of discussions, as we've described, with stakeholders from across the industry about patient identity and matching, and especially within the context of a unique patient identifier for the United States. And one of the most salient concerns that surrounds these discussions is privacy and security. And it is for that reason that we're starting with an entire block dedicated to privacy and security. It is my great pleasure to introduce Catherine Marchesini, who is ONC's privacy officer. Go ahead, Catherine, the floor is yours. Thanks.
Thanks for the introduction, Carmen. Good morning, everyone, and I would say happy Monday morning. I'm looking forward to today's session as patient identification and matching are key elements for interoperable health information exchange. And as electronic health information exchange becomes more prevalent, the accurate and efficient matching of patients to their records, particularly their health records, become a greater and more pressing priority. Whereas currently standards and methods used to identify and match patients to their health information, health records vary widely, and incorrectly matching a patient to a health record may have privacy and security and healthcare implications. Next slide, please. Today, my goal is to provide a federal perspective and some foundational privacy and security concerns, considerations as a backdrop to provide some context for the session's later presenters today in the group discussion. I'll talk briefly about some of the intersections between patient matching and privacy and security, including what HIPAA says, what HIPAA doesn't say regarding patient identifiers, as well as identity and broader matching topics, and then touch on some big picture privacy and security concerns in this area. Next slide, please. So generally, when people think about information privacy in healthcare, they usually always think about HIPAA first. So I'll start there and provide some basic information about HIPAA as a general kind of orientation and background to set the stage for a broader topic. So to start, the U.S. Department of Health and Human Services, the Office for Civil Rights, OCR for short, they administer the HIPAA privacy, security, and breach notification rules. Many of you are probably very familiar with this. As you'll see, this slide shows HIPAA's conceptual structure. It's very simplified, and you'll see it's what type of information HIPAA covers and protects. And you'll see here individually identifiable health information. It could be oral, electronic, on paper. I'll talk a little bit more on the next slide or the following slide, but I wanted to talk through just to set some context for what it covers. So now that you see what the information that is covered, who is covered? HIPAA actually establishes a list of the who's, what is referred to as covered entities and business associates, healthcare providers that are conducting covered electronic transactions under the rules. So this is not just clinicians. They fall into the category, but also relative pharmacies, labs, health plans, as well as healthcare clearinghouses. And the business associates are organizations or persons that are operating on behalf of or doing functions for those covered entities. So if an organization meets the criteria of being what is referred to as a covered entity or covered by HIPAA, they fall into the WHO category. And so once you fall into the WHO category, how does HIPAA protect it, or what must be done? HIPAA, also assigns data protection responsibilities, as well as, you can call them obligations, requirements, if you will, for the entities that they must follow. And you'll see here, there's just some items listed, very high level. There's conditions for using and disclosing information, as well as individual patients' rights, as well as minimum necessary areas where individual authorization is required. And then also under the HIPAA security role, you'll see listed there's technical, administrative, and physical safeguards that really focuses on maintaining the confidentiality, integrity, and availability of protected health information. There's also a separate role that focuses on breach notification. Next slide, please. So given the scope of today's session, I'll focus on a few specific areas, and you'll see on the slide here, this is a very simplified snapshot of what constitutes protected health information. And just to level set, protected health information is information, and this includes demographic information, which relates to an individual's past, present, or future physical harm and mental health or condition, dealing with the provision of healthcare of the individual, or the past, present, or future payment for the provision of healthcare to the individual. So you have a scope of what is health information, but also there's an and part of the definition. It deals with, if this information has to identify the individual, or for which there is a reasonable basis to believe that can be used to identify the individual. So the protected health information also includes many common identifiers. So this could be name, address, birth date, social security number. I'm sure folks listening in, as well as the presenters, will talk about that today. But when that identifier is able to be associated with the health information, that is what kind of triggers it to become protected health information. So the relationship between health information and the identifier is fundamental. Identifying information alone, so information by itself that doesn't have one of the 18 identifiers, such as a person's name, their residential address, or their phone number, it would not necessarily be designated as protected health information for HIPAA purposes. So in short, protected health information is healthcare related records that contain any of the 18 specific type of data or identifiers that can be used to identify the patient. Next slide, please. So sometimes these 18 identifiers are referred to as HIPAA identifiers. They are actually listed in the HIPAA privacy rule. Generally speaking, this is what makes qualifying health information identifiable. For purposes of HIPAA, therefore, it would be protected health information, and those entities I talked about a little earlier would need to follow certain requirements to protect the information. There sometimes is a misconception that because a data element is listed as an identifier, and therefore it's subject to HIPAA, the HIPAA privacy or the security rule, that people think that you can't use the information. Where in fact, generally speaking, covered entities, as mentioned, covered entities and their business associates would need to just protect the information and the identifier, just as if it was any other protected health information under HIPAA. So this includes information integrity, as well as areas relevant to breach. Next slide, please. So on the topic of HIPAA and identifiers, I wanted to highlight an area where this slide shows on a topic related to identification within HIPAA. This has to do with HIPAA identity verification and authority and the standards that are in the privacy and security rule. So generally speaking, prior to making a disclosure that's permitted by HIPAA, a covered entity must have, or I should say, they must verify the identity and the authority of the person that's requesting the information, as well as, particularly if it's not known to the covered entity of who that person is. And the privacy rule generally does not include specific or technical verification requirements. So it's flexible enough so that covered entities can fashion the procedures that fit to the size and the complexity of the organization. And this includes applying them to an electronic health information exchange environment. However, I did want to highlight that the covered entity must have written policies and procedures that are reasonably designed to verify the identification and the authority of the individual requesting the information. And this includes, the personal representative as well, where the covered entity doesn't know who the person is that's requesting the protected health information. And also, you'll see on the slide here, the HIPAA security role, as mentioned, which focuses on the confidentiality, integrity, and availability of the protected health information. I think for today's discussion, integrity is very important. There are complementary requirements with those on the HIPAA privacy rules, specifically dealing with administrative and technical safeguards regarding the authorization of the access and verifying that the person seeking the information is the person that they claim to be. Next slide, please. So other than the areas mentioned on the previous slide, the HIPAA rules do not really discuss patient identification and matching. Some often think that HIPAA prevents certain methods for patient matching, including, for example, a unique patient identifier. However, the actual underlying HIPAA statute that was passed in 1996 actually recognized that a unique patient identifier for individual is essential for the component of administrative simplification. So you can see on the slide here, as passed here, the HIPAA statute actually calls for the creation of a unique health identifier. The excerpt here really focuses on the HHS secretary to implement health data standards, including identifiers, so very similar to the security standards as well as recommendations around privacy. There's historically been a strong interest from industry as well as others that the federal government should play a role in helping to identify a unique health identifier, standards to help with patient matching. But I wanted to highlight that even though there may be this interest and there is the underlying HIPAA statute, for over 2 decades, there's been a federal law in which Congress has prohibited HHS from using any of its appropriated funds to develop a unique patient identifier or unique health identifier without the congressional approval, and therefore, limiting the broader adoption of this technique. Next slide, please. So I know I'm almost out at time, but wanted to highlight, separate from HIPAA, there's some associated policy and legal considerations when talking about patient matching and identification. There's some general concerns, and many of these identified to date, they're not unique to the topic at hand. They're similar to overarching concerns regarding identifiable health information more generally. So for example, incorrectly matching a patient to a record may have privacy and security and healthcare implications. So if patient information is inappropriately or wrongfully disclosed, treatment may be based on another patient's information. I'm sure folks are very familiar with this scenario in dealing with false positives, matching one patient's data with another, as well as another kind of topic around privacy focuses on when, let's say, a record or information about an individual indicates it's an affirmative match, but there is a restriction in some way, or that the patient has to require express permission to disclose it. In this situation, just even the acknowledgement that the patient has information at a particular location could convey private information. The other kind of 2 bigger areas deals with misusing identifiable information. So similar to unauthorized access, linkages, one of the risks associated with misusing the information, if it's for financial data, purchasing habit, using it in a discriminatory manner, identity theft, dealing with some other areas, particularly around security, around if you're having to transmit large batches of personally identifiable information, such as names, date of birth, address. The concern is that there's more identifiable data that's at risk of a breach if it's frequently transmitted. So that could be intercepted or stolen, and used against the individual. Next slide, please. So that's just a quick highlight of some of the privacy and security legal and policy considerations, just hopefully, to provide some backdrop for today's discussion. And the challenge, really is, how do you link patient records while taking into account their privacy and security interests? And how do we associate patient information accurately with proper patient records, yet protecting the patient anonymity? So I look forward to today's discussion and from the various presenters. So with that, I'll turn it back over to Carmen. Carmen?
Thanks, Catherine. That was excellent. So next, I'm excited to introduce Dan Saddam, who's Chief Technology Officer at Nextgate. Dan.
Thank you, Carmen. Just a quick sound check, as everyone can everybody hear me? Carmen?
Yes.
Oh, I'm just want to making
Thank
sure
you.
everyone can hear me. Okay, I know we had some issues in
Okay.
getting connected. So good morning, everybody, and I would like to thank the ONC for an opportunity to present our point of view in terms of where we see patient identity moving in the future. And what I'd like to discuss is really this notion that the way towards the future is in a federated approach to managing patient identity. If we move to the first slide, what I wanted to start with is basically just a recap of where we are today. And it's a good segue actually from where Catherine left off. As most that are listening to this are probably well aware, the EMPI is basically one of the prominent ways that data is handled today to solve this problem. And that's essentially the line of business that Nextgate is in. And our point of view is to kind of talk about where we see the EMPI moving in the years ahead. So on the left-hand side is a very simple depiction of its very simple concept. And it's essentially that data that's coming from various registration systems and other points of contact with the patient are aggregated together in order to form both an enterprise identifier for that healthcare enterprise, as well as a set of demographics. Now, this sort of process, even though it's in play for the last 20 years, is really, as you can imagine, not 100%. And a lot of the discussion that has been follow up is really on why are we not able to reach that 100% mark. At the same time, and this is where I think it's exactly along the lines of what Catherine was describing, how do we get to the 100% mark without inadvertently sacrificing the privacy or the security for the patient? And I think a lot of that also has to do with how we can better leverage the data that we have today. So let's talk a little bit on the next slide about some of the key barriers, because I don't think that the key barriers are largely technological. In fact, if you look at it from our perspective, the key barriers are really around the adoption of standards. So for example, standards that help to define how to communicate patient information from one system to another system, and also how to look up patient information in a way that allows interoperability. The IHE has been for a very long time promoting standards in this space, which I'll talk about in a couple of slides up ahead. It's the lack of adoption for those kinds of standards that, from our view of it, has caused some major problems in how well we're able to identify patients. The other aspect is around the data governance. It's really quite simple. If there's consistency in how data is captured, the demographics that Catherine put up on the screen, then we're going to be able to do a much better job in matching the records together, even without a central identifier or other technologies at play. And we see that with many of the organizations that have strong data governance policies, we're able to do a much more effective job in matching. And then finally, the elephant in the room is really patient consent. So long as the patient is kind of this unwitting bystander to all the things that are happening to him or her, then it's going to be very difficult to get to a point where we can control the flow of information and control the identifying features of that information. And I'll talk about that towards the end. So on the next slide, what I wanted to talk about is going back to the notion of standards and the adoption of standards. And this slide is simply depicting the process that typically is employed when a patient comes to a point of care. And it's all about this registration process, which largely even today, after so many years of standards and testing and interoperability events and all these things that are promoted, it's largely something that happens in a kind of silo. And so that silo is represented by that middle box. It's whatever system is dealing with the patient at that time. And a person that's performing the process of determining the patient's identity is only looking at it from the perspective of that one individual system. The EMPI, which we sit on the right-hand side of this equation, is basically listening for that traffic and trying to do the best that it can in formulating a single best record out of that and an enterprise identifier. And as I said, it is quite successful in doing so, in the upper 90s in the percentages, but still that leaves a few percentage of records that are ambiguous in nature. If we look at the next slide, then really the key aspect around improving and using the data that we have today in a better way is a very simple concept. And it's essentially that the information about a patient should not be centralized in any one particular application, but should basically be out of the control of one application and decentralized. Now, decentralized in the sense of an healthcare enterprise is, the closest approximation we have today is an EMPI, where not one particular system is in charge of maintaining the demographics or identifiers for the institution or the enterprise, but rather collectively all the applications are querying the EMPI to determine the patient's identity. This has some very obvious benefits. The most clear one is the fact that if one application was unaware of the patient's existence simply because it was a different facility or a different point of care, then the EMPI is able to provide that kind of holistic picture of where that patient may have been seen and prior demographics that were captured at that time. This is a very effective technique. I wish I could say that a larger percentage of our customers are using this. Largely that is a limitation of the systems not using some of the standards that are there, such as the patient demographic query. And so part of the feedback that we'd like to provide this morning is really around better use of standards and enforcing those standards so that applications can begin to leverage some existing capabilities today. If we look at the next slide, then what I'd like to talk a little bit about is the consistent capture of information. And this was some of the attributes that Catherine was listing in her presentation. If these kinds of attributes, and we've shown here in this slide is the US CDI set, if this information is captured consistently across applications, then the ability to match this information would clearly be far better. And part of what we see as kind of lacking in the industry are also standards around the edge cases. The edge cases is if you look at where the few percentages of mismatches or problematic matches are, they tend to be in the areas of things like how newborns are handled, so maternity wards, emergency patients, the underserved and the homeless. Those populations, there are not clear standards on how data should be captured, and therefore there's a lot of issues in being able to link that data. So again, very simple concepts and would be very effective in improving the matching. And now on the final slide, then let's talk about what can we do beyond existing data and existing standards and all of that. There has been a lot of talk in the industry about being able to integrate additional data sources to help solve this problem of the identity management. So the notion of using, for example, public records or financial records, maybe even consumer applications and data to fill in the gaps of where patient information is missing. So it's basically admitting the fact that data governance in some cases is weak, and that perhaps standards are not being used to help communicate patient information. Can we fill the gap simply by looking outside? And we looked at this very carefully, and the slides that come ahead, actually, if we could just go one further, really get into this topic of how effective is it to use data that's collected outside of healthcare in establishing the patient's identity. And what this particular graph is showing is for one of our customers that we did a study for, we have on the y-axis pairs of records that are matching. Essentially, they represent the same individual. And on the x-axis is the age of the patient. And what you can see is that the hatched lines represent cases where the EMPI, based on the data that we collect today, was able to match the records on its own. The gray on the background represents cases where there was ambiguity and we weren't sure. And the blue trough in the middle represents cases where reference data that's collected external from the enterprise that fed the EMPI was able to improve the matching. If we look at the slide ahead, then what we're doing is double clicking into that center portion. So this becomes a zoom of basically the ambiguous matches. Now keep in mind that this particular client, we were talking about 97+% matching. So this is the very top of the mountain, if you will, of records. And what you can see here is that external data, as represented by the dark blue, certainly did improve the matching, at least for the adult population, mainly because minors, first of all, are covered by laws that prevent the dissemination of data, but also simply because they don't have much of a digital footprint that would have value in determining prior addresses, prior phone numbers, other things like that. So if you look at the overall impact of this sort of thing, it's about 1/3 of the ambiguous record pairs. So clearly it has benefit. It is the reason why we've introduced this capability into our EMPI as well, but it is not by any means some sort of revolutionary silver bullet that would put an end, to the problem of patient identification. And so what I'd like to do is really close on this last slide here, which is where are things going in the future? And I'm not here to provide specific details, except to say that, if we look at how things will evolve in the future and whether it's some sort of national patient identifier or other approaches, I think there's certain things that are clear. First of all, that it has to be a standards-based approach. The only way that applications, best-of-breed applications, different healthcare enterprises, and enterprises outside of healthcare will ever get to a point that they can communicate consistently and with security any information about a patient is through standards. And some of the emerging standards, of which I'm sure there's a number of different speakers that are going to talk about this today, are things like decentralized identifiers. This is a concept where the identifier for an individual is not owned by any particular organization, but is established independent of organizations. And part of this is driven through blockchain technology, which again has this notion of being verifiable, but at the same public, and at the same time, something that is immutable and cannot be tampered with. This is, in our view, really just an extension to the problem that I talked about in the beginning, where individual applications within the healthcare enterprise are unwilling to cede control over the patient's identity to the EMPI and query the EMPI in real time. It's not really any different when we start to talk about at a broader scale, being able to share information. There has to be this notion that control is ceded over to a more decentralized type of environment. And another standard that clearly is going to make a big impact is user-managed access to UMA. And the ability to authorize with the consent of the patient or through navigators that are managing the consent of the patient to be able to share information in a way that it clearly shows where the data is flowing and is not simply some sort of centralized store that is waiting to be hacked. And so in summary, what I would say is that there is a role for all of these different sources of information to play in improving the patient identification. It is not likely that simply centralizing all of this is going to get us anywhere, but rather relying on standards that help us decentralize the management of the data that will get us closer to that goal. So with that, again, I'd like to say thank you to the ONC for allowing us to express our opinion this morning, and we look forward to what all of the other presenters have to say today.
Great, thanks, Dan. Next, we're going to continue on the privacy and security block. And next, I'd like to introduce Dr. Barry Hyde, who is founder and chief scientist of Global Patient Identifiers. Dr. Hyde.
Thank you, Carmen, and thank you for the opportunity to share some of our experience with the group today. Is my sound okay?
Perfect.
Great. 30 years ago, I participated in an ASTM medical informatics committee that spent a lot of time agonizing about how to secure the incredibly valuable patient identifiable information that a national healthcare identifier system would process. We considered a variety of options and finally concluded that the only way we could adequately protect that patient information was to never have it in the first place. In our opinion, this is the most critical security requirement of any NHID system. Can we go to the next slide, please? The value of a PII database is proportional to the number of patients it covers and the breadth of the information it contains on each patient. A nationwide PII database would represent an irresistible honeypot. Not only would hackers be drawn to it, so would data miners, politicians, law enforcement, curiosity seekers, foreign governments, and medical researchers. In today's IT environment, it appears hopeless to try to defend any facility against such an array of determined attackers. A much more feasible and predictable approach is to eliminate the incentive for all of these actors by designing the system such that there is no such honeypot for them to exploit. Now, in the interest of full disclosure, I'm the chief scientist for Global Patient Identifiers Incorporated, GPII, a company that has designed and developed a demonstration of a patient identification system that never processes PII at its core. It has no centralized database of PII. As strange as it may seem for a national patient identification system, this approach has yielded an identification system that can meet all of the requirements we will review briefly today and many others. We believe that any discussion of NHID adoption must start with an exhaustive analysis of requirements for that system. And today I will review just two of those categories, security and privacy. Data security must be ensured using obvious methods like encrypting data both in transit and at rest. However, there are other aspects of data security that also must be considered. For example, any system that involves interaction with human beings, no matter how well it is designed, will encounter errors. If we wish that system to deliver fully accurate results, it follows that there must be mechanisms that enable errors, once detected, to be fully corrected. For example, it must be possible to fully restore the integrity of a patient's identity following any human data input error. Perhaps more importantly, healthcare is plagued by fraudulent activity. The NHID system must be designed to prevent as much of this fraudulent activity as is possible and to repair identity integrity once violations of that integrity are identified. For example, the system must be able to recover completely and inexpensively from a data breach. Any patient whose identity has been compromised must be assured that the system has restored the integrity of their identity such that their access to the healthcare services is not interrupted. There must not be any barriers preventing patient identification services delivery to any individual who needs medical care. Language, ability to pay, disabilities, insurance status, nationality, and any other barriers must be eliminated to ensure that proper patient identification and record linkage can be offered to every individual who needs medical care. Let's go to the next slide. Let's look briefly at patient privacy. Most people will agree that the privacy of their healthcare data is extremely important, and yet the current mechanism of healthcare consents does not meet many of the privacy needs we know about. Because every patient experience is unique, the privacy paradigm embedded in the NHID system must be so simple and so flexible that each patient can easily adapt it to meet their own unique set of requirements, even as those requirements evolve over time. This slide provides an overview of the GPII approach to privacy. Each person has an open identifier that is linked to all medical information that that patient wants to be available to all of her caregivers. In addition, however, she can obtain one or more private identifiers that are anonymous. Each of these anonymous identifiers is linked to a patient-defined set of information that the patient wishes to manage separately from a privacy perspective. The patient determines if she needs private identifiers. If so, how many, and what data they are associated with. For each clinical encounter, the patient uses her open identifier and may choose whether to also produce one or more private identifiers. This controls what information the patient presents for that caregiving episode. Using this scheme, each patient can tailor the privacy of their clinical information according to their specific clinical situation and their perceived privacy requirements. Next slide, please. Anonymity is a critical requirement for many instances of care delivery in the United States. But traditional patient identification strategies cannot perform accurate patient linkage if the patient is anonymous. We believe the NHID system must provide the ability for fully accurate record linkage even when the patient requires full anonymity. For example, such anonymity may be of value when performing COVID-19 contact tracing. There are certain situations, such as the administration of life-saving emergency care, where the requirements of patient privacy conflict with the need to guarantee patient safety. The NHID system must contain mechanisms, such as break the glass, that enable the system to offer capabilities that balance these conflicting needs. Whatever patient identification system is implemented based on this work, it must be implemented in a manner that enables it to be permanent. Not only must its performance and anonymity capabilities be sufficient to ensure that it can serve for many generations, it must also have sufficient flexibility to evolve in the future to meet needs that are not currently foreseeable. Next slide. In such a brief presentation, we cannot cover even a fraction of an NHID system's requirements. We have listed more here, several of which will be viewed as difficult or impossible for the U.S. healthcare system to achieve. But with more time, we are happy to expand upon any of these and how they can indeed be achieved. I want to thank you for the opportunity to share some of our experience with the group today, and we look forward to further dialogue as this project proceeds. I'll turn it back to you.
Thank you. Great, thanks, Dr. Hyde. Next up, we have a discussion on privacy preserving record linkage, led by Dr. Pradeep Padilla, who is a public health informaticist fellow at the CDC, and Andrew Gorowitz, a principal software systems engineer at MitraCore. Pradeep? I think you're still on mute. Try it one more time. I know it's a double. There you go. Yes, much better. Thank you.
Okay, good morning, everyone. Happy Monday. Thank you, Carmen. Thank you for giving us an opportunity to present at this forum. Can we go to the next slide, please? Yeah, today with my colleague, Andy Gregorowitz, I'm going to present on the privacy preserving record linkage. This is a high-level overview of the concept. Next slide, please. So the views expressed in this presentation are those of us, the presenters, and not that of the organizations that we are associated with. Next slide, please. So the inspiration. So this is a good segue into the topic of record linkage, as many of the previous presenters have talked about it. So the inspiration for this is the integration and linkage of data from multiple data sources is required in order to deduplicate records associated with the same individual so that we are not overinflating the measures, as well as to fill the gaps and enrich the information that is currently existing, as well as improve the data quality of some of the data elements that we are considering for the record linkage approach, while increasing the research reliability and validity, and also to generate a more comprehensive view of the outcomes that we are trying to measure as a part of our strategic approach. At the same time, we do acknowledge that lack of a unique identifier means that the linkage is dependent on personally identifiable information, and personally identifiable information creates the security and privacy challenges. Next slide, please. So record linkage. Record linkage is the concept of bringing data from multiple data sources to join information related to the same individual. And there are two broad categories of the approaches within record linkage, which is the clear text record linkage that is dependent on directly accessing the identifiers or the identifiable information, whereas the second approach is the privacy preserving record linkage approach. So this is the approach that we are going to focus on today's presentation. Next slide, please. As we are talking about privacy and security concerns, how do we protect the data while still working towards accomplishing our goal of bringing data together related to the same individual? So data governance is the key pillar that helps us in understanding as well as designing the structure to accomplish the record linkage. So data governance is more than data management. Data governance helps in ensuring the safety, reliability, and trustworthiness of the data, as well as it helps in determining what is the approach that we need to take in order to establish the linkage. So is it the approach like a trusted third party? So which is an entity that can be trusted with to protect the personally identifiable information as well as securing the data? Or is it a semi-trusted third party, an entity which can be trusted to perform the computations faithfully, but not necessarily to protect the data? So the bottom line is the actions completed by a semi-trusted third party may also be accomplished by a trusted third party. Next slide, please. So data governance helps us in clearly delineating the different entities that form a part of the record linkage approach, which is the data sources, the governance structure, which helps us in understanding the intermediary approach that brings the data together, and the secure network. So using these icons, we are going to display a high-level overview of the privacy preserving record linkage later on in the presentation. Next slide, please. So privacy preserving record linkage is also referred to as PPRL. The aim of PPRL is to address how multiple data sources or organizations can identify and bring together the information related to the same individual without disclosing any identifiable information, while accomplishing this while including techniques that are not vulnerable to any frequency attacks, dictionary attacks, cryptanalysis attacks, and collusion attacks, and at the same time ensuring the high level precision and recall that can be accomplished with the record linkage approach. However, it still requires access to the identifiable data at the sources, at the data sources. So PPRL, or the privacy preserving record linkage approach, employs the techniques from cryptography in order to protect the privacy and security of the data. Next slide, please. So this is a very high-level schematic of the PPRL approach. It starts with the identification of the two data sources. This can be a hospital and a community-based healthcare center. And the second now comes into play the intermediary, which is a trusted third party. The trusted third party helps in creating secure keys and transmits them to these individual organizations. And these secure keys are used by the individual organizations to encrypt the data or hash the data. And all this happens behind the firewalls of those organizations. So no identifiable information is being transmitted. So once the data is hashed, Now the hash data will be distributed to a semi-trusted third party. So once the semi-trusted third party receives the encrypted data, the deduplication, identification of unique individuals, and accomplishment of the linkage approach happens, following which the distributed linked data will be sent back to the data sources. Next slide, please.
So Pradeep, are you handing it over to me here? Can folks hear me?
We can.
Okay. All right. Thank you, Pradeep. From here, I'll pick up and talk about some of the different techniques that are used for privacy preserving record linkage. And we've broken those down into 3 high-level categories. One of them is hash encoding, where you wind up using a one-way hash. You could imagine something like SHA-256 to encode data, and then compare encrypted hash values. We'll walk through an example of that. There's also secure multi-party computation. That is where computing activities are distributed across multiple participants, typically using techniques like homomorphic encryption. We're not going to dig too deeply into that. And then finally, we'll also talk about Bloom filter encoding, where the data that the PII is fragmented and put into a probabilistic data structure called a Bloom filter. And what's nice about that is that you can use that to calculate similarity between 2 encrypted values. So if we go to the next slide. If we were to compare some of these different techniques, you have hash encoding. This is a pretty simplistic approach, so it's low complexity. The downside to using just purely hash encoding for PPRL is that it only allows for exact matches. And I'm sure if anybody is familiar with the identity management space and record linkage space, depending only on exact matches is probably not going to be a solution that's acceptable to you. But it is one approach. For secure multi-party computation, this is an emerging technology, and it mixes the record linkage with actions to be taken on the linked data. So you could, you can do things like identify the individuals that should be matched, but it's also going to include the computation piece, so answering things like research questions on the linked data. So it sort of mixes both things. And again, this is an emerging technology. We're not going to dive too deeply into it. And then finally, Bloom filter encoding. This is a little bit higher complexity. We'll get into how you can build a Bloom filter. But the nice part about looking at a Bloom filter is that it allows for probabilistic matching, so that you can get to that level of record linkage that you would like, where you can identify nicknames and typos and things, or match across nicknames and typos and things of that nature. So next slide, please. So this gives you an idea of what using hash encoding for PPRL would look like. This is a concrete example. So imagine I have 2 different providers. We're actually using PII here. This is the names, birth dates, and birth states of some US presidents. So we have George Washington, Thomas Jefferson, and James Monroe at our provider on the left, and we have George Washington, John Adams, James Madison, and James Monroe at the provider on the right. We've taken those strings and we've passed them through a SHA-1. So we are passing them through a hashing algorithm. So you can see the resulting hashes that come through there. And then that would represent the typical type of operation that would happen behind an organization's firewall. So none of the information, none of that PII is leaving that organization's firewall. It's only the hashed values that get transmitted out of there. So the information's garbled. It would be hard to reverse engineer. We are sort of glossing over some things that Pradeep had already talked about with using things like a secret or salt value to add to this. So we're kind of skipping over that step. But then you would have a semi-trusted third party like Pradeep described that would be able to compare these hash values, and we would be able to identify linkages so we could see that the records for George Washington and James Monroe exist at both providers, and then we could use that to establish a link without sharing their PII. So that's how a simple hashing approach works. So if we go to our next slide, That takes us from PPRL 101 up to PPRL 201, where we talk about, PPRL starts with hashing, but plain hashing or hashing with salt works for exact matches. So again, we have to assume that there are no typos, that there are no changes in address or things like that, which again, everyone here knows that that's just not going to cut it. So we can introduce some new technologies here to help us deal with those sorts of things, and that is Bloom filters plus this notion of something called a dice coefficient. So if we move to our next slide, Bloom filters allow us to build these probabilistic data structures. There's a link here in the presentation that will take you to an open website that allow you to build your own Bloom filter. But the key thing to take away from this is that a Bloom filter works by taking a hashing algorithm, and so you'll get a hash value when you take a particular piece of information. And if you hash that, and then you have a Bloom filter that has a particular size. So here we're looking at a Bloom filter that has a size of 14 bits. So if you hash something, you'll get a result out of that. That's like a big number. You take that big number, you divide that by the size of your Bloom filter. So in this case, that would be 14. And then you use the remainder of that to set the particular bit in the Bloom filter. Now, what we can do here when we're building a Bloom filter is we can actually break up the information. So what I can do is I can take my name, my nickname, Andy, and I can break that up into two different pieces, AN and DY. And I can pass that through a hashing algorithm, and it would wind up coming up with two different values, and I could use those to set the values in this particular Bloom filter. So if we go to the next slide, what that allows us to do is, for most privacy-preserving record linkage techniques that are using a Bloom filter approach, is that they will break up information, and then they'll be able to compare that using this thing called the Sorensen dice coefficient, or dice coefficient for short. So if you look at my nickname, which probably appears in some of my records, which is Andy, and you can break that up into different fragments, AN and D and DY. And you could look at the proper name that appears on my birth certificate, Andrew, and you can see how that is broken up. And we can run that through a Bloom filter. So we can build a Bloom filter out of both of those. And you'll see the different bits in the Bloom filter that get set up there. And then what we can do is we can compute this thing called a dice coefficient. It's also the same as an F1 score for folks that are familiar with that, where I look at the true positives up at the top, and I divide that by the true positives plus the false positives plus the false negatives. And if we actually go to the next slide, what you'll see is I've color coded some of these here. So you can see that I have the false positives in red down at the bottom, viewed in one perspective. So down at the bottom, I set the bits 0 and 1. Those are false positive. True positives are in green. And you can see we actually have a false negative there, that 4 that is missing. So what we can do is we can actually use this information to compute what is called this dice coefficient. So you can just plug in all of the information that you have here and come up with a number. So this, if you actually plug in the information into the fraction, you can get to 0.57. So overall, you can use this technique. We can pull in things like names, addresses, phone numbers, and come up with an overall number, and then we can use that to set a particular threshold, so that when you're building your matching algorithm, you can say if my dice coefficient is over 0.8, I'll consider it a match versus not a match. Depending on your scenario, you might, well, you can't really do manual adjudication in this case because you don't have access to the information, but that is the type of technique that you would use to determine whether something is a match or not a match. So next slide, please. So that's your brief crash course on privacy preserving record linkage. Hopefully you found that informative. And with that, I'll turn it back over to you, Carmen.
Thank you so much, Andy. That was great. And Pradeep. We're going to wrap up the privacy and security block on the agenda with Dr. Louis Moss, who is the Chief Technology Officer for EMR Direct. Dr. Moss.
Thank you, Carmen. I'm really happy to be here, and thank you for the introduction. I'll be speaking today about privacy and security standards for digital identity. Specifically, I'll try to discuss this as they can be applied to patient identity in healthcare. As Carmen mentioned, I'm the CTO at EMR Direct. I'm also co-lead of the Security Tiger team for ONC's Fire at Scale Task Force, also known as FAST, and I do quite a bit of work in the standards development space with a number of SDOs, including HL7, OpenID Foundation, UDAP.org, and Direct Trust. So you'll be hearing about some of those standards today. Next slide, please. Since we'll be talking about privacy and security standards, I wanted to take a second here and start with a few basic definitions. Now, obviously, there are lots of ways to define privacy and security, but I think these simple definitions on the screen work well to set a stage for discussion about patient identity. So privacy, the right to control how your personal information is used or disclosed. And then closely related to that, security, which in the context of privacy is the mechanisms used to protect the privacy of your personal information. So these are fairly broad definitions, and protecting the privacy of digital identities is obviously more than just technology. There are also administrative protections, think policies and procedures about how data is collected and by whom. There are physical protections, like who can enter file rooms and facilities, who can service equipment, and how that's controlled, and things like that. But I'm going to focus on technical standards. With the growing use of internet accessible APIs and today's working sessions focus on digital health, I'd like to speak about 4 open technical standards in use today or evolving today that relate to protecting the privacy of patient identity in that setting. So for the most part, these are pretty elaborate protocols with lots of options and extensions. And in 15 minutes, I'm not going to get too deep into the weeds about these technologies, but I'll give you some references to follow up on these. And I do hope to highlight some of the facets of the standards that pertain specifically to or apply specifically in the context of patient identity and patient matching. Next slide, please. All right, OAuth 2. I'm sure many of you have heard about the OAuth authorization framework. This is a standard released by the Internet Engineering Task Force, or IETF, in 2012. We'll call this an authorization protocol because that's what they call it. And it comes in various flavors, but I think the most common form in the context of patient use today is a variant called the authorization code flow. In simple terms, the purpose of the OAuth 2.0 authorization code flow is to let you, the user, authorize an app, and we'll get into that a little bit more, what an app is, to do something with the data that you have rights to. In the patient space, we think a lot about, letting an app access your health records. It could also be accessing your identity information, which overlaps to, quite a bit, in fact, with health records in many cases. On the internet, you may have seen OAuth 2.0 in action when the pop-up comes up asking you to sign into a service with a message along the lines of, the ABC app would like to access your calendar. Do you authorize this? Something like that. Important features of OAuth 2.0 over other earlier technologies, and the reason why this is so popular today. You don't have to share your credentials with the app. You keep those secret, and so in essence, the app doesn't even really need to know who you are, and you can control, at least in most implementations, what you share with that app. So let me go back to that. What is an app? I mean, I'm not just talking about, an app on your smartphone. In the OAuth world, it's really any software operator or a software run by any operator that wants to access something you control. So for example, this could be a patient check-in system at a hospital or a clinic, or it could be a registration system for a therapeutic research trial, or some kind of national health information sharing platform. I mean, don't look at app too narrowly. That's just a term that comes up in these standards a lot. But essentially it's somebody or something that wants access to data you control. How finely you can authorize what you share in these apps, we generally express that in a language called scopes or OAuth scopes. These could be as simple as all or none authorizations to all of the data on a server about you or that you own, if you will, or something as narrow as share only my birth date or share only access to my current medications or something like that. So there's a lot of power in OAuth 2 and a lot of flexibility to do that. And that leads me to the next standard. If we go to the next slide, please. This is OpenID Connect, also called OIDC. So OpenID Connect from about 2014 from the OpenID Foundation. We'll call this an authentication protocol, and it builds on OAuth 2. So what this lets the app, which in the OpenID world is called the relying party, it allows the relying party to ask you, the user, to be authenticated by an identity provider. The identity provider is some entity that knows who you are and knows something about you and knows enough about how to make sure it's actually you on the other end. And we'll get into that a little bit here, but there are many sessions later today in other blocks about authenticators and such, so we'll just not dive too deep into that here. The key facet that ties this in with patient identity and potentially patient matching is that the IDP essentially, they have an identifier that's uniquely assigned to you that they can provide the relying party with. And possibly also identity attributes that they can choose to share, usually with your explicit consent, things like your name, your date of birth, and other personal information. So OIDC and what the IDP shares with you obviously have a lot of implications to privacy and the personal information that the relying party can get about you. Now, in traditional use, this is primarily so that the app can figure out who you are because they believe the OIDC IDP, the identity provider, knows who you are. So that's one use, but it can also be used to confirm that you control, we can go to the next slide, please, that you control an identifier that is being presented, and also to try to match you up against information that the IDP may have. So let's pause here for a second on this construct that OIDC lets you prove to the relying party that you are the person associated with an identifier. This is an important concept, okay? Identifiers are not authenticators. Authenticators are a technology that you use to establish your connection to a particular account, if you will, and that account is represented by the identifier. Think about the idea of social security numbers, something we talked about a lot in the identity space as a example of what not to do in a lot of cases. Historically, the social security number was quasi-private, and knowledge of that identifier was enough for you to prove that you were that person. And clearly that didn't work well, and we see all of the problems that evolved from that. So moving away from that model is important, and having identifiers that can be freely shared and are not private and don't need to be hidden is very important, especially in a working session about patient identity and possible solutions where identifiers are shared, right? But at the same time, you want to have a mechanism where you, the patient coming into that check-in or that registration site, is able to say, here's my identifier, and I'm going to prove it to you. Right, so that's one of the advantages of OIDC. And there are other ways to do this, encoding digital identities on smart cards and other physical approaches where you that may revolve around in-person biometric collections, things like that. Others will be talking about things like that today. But in the internet API ecosystem, OIDC is probably one of the most common ways to do this. The other bullet point here that I mentioned Also important to the privacy is that for the most part, OIDC, at least most implementations of it, let you decide which, if any, identity attributes you want to share. So it could be that the only thing that this relying party wants from you is the identifier. Either to confirm it's the same identifier that you gave them, so that it can run it against a search against other entities that are using such an identifier, or to discover that identifier, because presumably it being unique, it's going to be a complex number you might not be able to remember, but you wouldn't have to, because the OIDC protocol would give that relying party the full long identifier. Now, there are options here where different entities can get different identifiers to further enhance privacy, but those somewhat don't necessarily match up with the idea of shared identifiers to enhance patient matching, so I won't get into that, but just let it be said there are many variations on how this can be implemented. Another issue or another benefit, depending on your viewpoint, of OpenID Connect is that it's a back channel communication between the relying party and the IDP. The relying party gets the data directly from the IDP. It doesn't have to pass through other third parties to get there. So in theory, that also enhances privacy. There is the flip side of that, because the data comes directly from the IDP, the identity provider may be able to know, if it tracks this information, everyone who's asked for information about you, or every place that you've authenticated, and may be able to infer things about you from that. So clearly it's important that OpenID Connect providers are well-behaved entities, and that a governance structure exists for their behavior, and we'll get into that a little bit in a minute. Let's do a little time check here. Okay, excellent. We'll go to the next slide, please. I'll talk next about UDAP, the Unified Data Access Profiles. These are a draft for trial use profiles that are mostly published in 2018 and 2019 by udap.org, in which I participate quite a bit. So I'll describe these effectively as a trust network protocol. And like OIDC built on OAuth, the UDAP profiles build on OAuth 2.0 and OpenID Connect. The core unifying factor here is that these profiles are intended to scale these open API ecosystems via trust communities. And we'll hear about trust communities and trust frameworks a little more in later sessions. But essentially the goal here is to manage the proliferation of app and user identities and create a trustable network where you can establish, for example, that an OIDC provider is well behaved and can be trusted in the data that they're providing to you and does meet certain minimum standards and things of that nature. There are a lot of UDAP profiles, and they're not just about user identity. There are also profiles that relate to the identities of apps, app operators, data holders, IDPs, and all that. But I'm going to focus for the purposes of this working session on those that are closest in their relationship to patient identity. We can go to the next slide, please. That's going to be specifically the UDAP tiered OAuth profile. Tiered OAuth builds on OIDC, essentially letting a data holder in the middle access information about you from a trusted IDP. It's a way to, in a sense, federate the IDP usage so that, unlike the usual case where the OIDC provider in healthcare more commonly than not is also the entity that holds your data, in this case they can be more effectively segregated and created in a flexible way where you don't necessarily have to hard code everything, and also provide a way that you can understand these OIDC providers are trusted. When you think about how OIDC is used, sometimes in the internet today, you may have experienced this, this sign in with Facebook or sign in with Google type approaches. This works primarily because most people have accounts with Google or Facebook, or at least enough that the entities that want to offer this sign in with Facebook or Google can do such a thing. In tiered OAuth, essentially you as the user can can alert the entity that's asking for you to be authenticated who you'd like to authenticate you, and they can determine if that's actually a trusted IDP or not, and a little negotiation there can take place to get your identity information, or at least your authentication information, from your preferred IDP. So like OIDC, it also has the benefits of the back channel communications, leverages the ability for privacy to be used, to be managed by you as to which attributes you share. And let me add here, just after hearing the last session, the identity information shared by the IDP doesn't need to be shared in the clear, right? Although that's clearly how, no pun intended, how it's most frequently done today. The identity provider could just as easily be using any of the privacy preserving technologies that Andrew covered earlier this hour to reduce that honeypot appeal that Barry mentioned a few blocks back. About identity data that's centralized. So if for example, that personal identity information is hashed and even stored in a way that it can only really be used for confirmation, that reduces the importance of the data as a target, even though it's centralized. So in this case, that information can be used to basically, so a relying party can confirm that it holds the same data about you, and it's collected and authenticated you in other ways. And this is more about like confirming, okay, now this identifier is about me. I've got the person here with me potentially, and I've identified them previously myself, and now I'm confirming this is in fact the same person. The other issue, or other item I'd like to touch on about UDAP and that it's a trust network is that, the trust network this is an important component here, because this lets the community, and there can be more than one and they can overlap, but this lets a community set the bar that they need or they want for all the aspects of identity that I'm not talking about. The governance issues around identity proofing, how it's done, what's good enough, what evidence you have to present to prove you're you in the first place. Things like authenticators, how securely is your account controlled? Can you sign in with a simple username and password that's tied to your email address for recovery? Or is this a more complex device-based authentication where you have to have a specific device and unlock it with your thumbprint, like you'll hear later about today in one of the FIDO sessions? All that works. So UDAP doesn't specify that. It lets the trust community define what's good enough for which use case. And I think that's also important. There are profiles as well for delegation and authorization, chains to be established via digital signatures that I don't have time to talk about today, but I do see a few comments in the box that I'll just reference there. And there are some resources that I'll direct you to at the end. Since I am down to the last couple minutes, let's go to the next slide. I'm not going to talk too much about self-sovereign identities because I know there are specific talks about this, but let's say this is a rapidly evolving area of digital identity. This is primarily, and there are lots of flavors of this, but I'm going to focus mostly on the SSI flavor managed by the World Wide Web Consortium, or W3C. This is, when I say this is rapidly evolving, let's say the last working draft was published on July 31st. So just over 4 weeks ago. It's still changing quickly. So down the horizon, this is hopefully will be more standardized, but lots of work going on, lots of interested parties because of the focus on user-centric identity. So SSI tries to take away the perceived privacy limitations of having centralized identity providers in a different way by essentially removing that from any central space and having this construct of digital wallets where identity providers, instead of passing data directly to entities, give them to you to hold in your digital wallet, and then you pass them around as you need it. So decentralized identifiers, or DIDs, are one of the mechanisms for doing this. They have their own authentication and sharing of attributes protocols. Something called verifiable credentials works well with DIDs. It's similar to the certifications and endorsements that's built into UDAP, for example. And there are some ways that SSI could be integrated in the future. DIDs are basically uniform resource identifiers, or URIs, which is the core identifier in UDAP workflows, for example. So as this framework matures, it can be added in as well. So there are certainly some open issues currently in operationalizing these SSI approaches, particularly around governance. You know, that the actors are behaving is much harder to manage in a decentralized environment, but there's work going on in that as well. And this will tie into the next block on trust frameworks to some degree. So I will stop there. Thank you, Carmen. Next slide has some references. Yeah, here's some references for anyone interested to do some deeper reading.
Great, that's perfect. That was incredibly informative. Thank you so much. So that is wrapping up our privacy and security block on the agenda, but privacy and security never really leaves the discussion. You'll see it peppered throughout other presentations throughout the day. But right now we're ready to launch into trust frameworks. And Colin Wallace, who's the Executive Director of the Kantara Initiative, is going to take it away. Colin.
Thanks very much, Carmen. And I want to, just as we start off this session with the Trust Frameworks block, I do want to just point back to the privacy and security block, because much of what the discussion there and the raising of those standards and the architectures and so on is pretty critical, is essential. They're essential really to what goes on with the trust frameworks and the trust framework providers. As Carmen said, my name is Colin Wallace. I'm the Executive Director of Kantara Initiative, and you'll hear perhaps in the first couple of slides, 2 or 3 slides, a little bit about Kantara to try to set the context, if you like, for what we're going to say a little bit further on. Next slide, please. Thanks. So very briefly, and I'm going to have two slides like this, to just give you a sort of a kind of a level set, you know, that we're a non-profit industry consortium, and we work in the area of innovation, R&D, applied R&D, standardization, best practice and assurance, and we operate a trust framework, or a trust framework provider, and we do that in a very specific way. You'll find as we go on to this that trust frameworks come in all shapes, sizes and hues. So it's important not to kind of think of them as one size fits all. We also do standards I talked about above. UMA is already mentioned. Thank you, Daniel, and consent receipt as well. Next slide, please. A deeper dive then into, you know, putting Kantara on a page. It's actually 3 organizations, 3 separate, financially separate organizations, a public good charity, an educational foundation, and Kantara Europe, based in Tallinn, Estonia. So all 3 of them actually share the same ethos and ethics around no barriers to participation, to transparency, community development, and so on, and very focused towards the way in which the focus is towards the consumer and their concerns around patient-centric identity and patient-centric privacy. So it's certainly directed in that way, which makes us, you know, kind of appealing for some folks, if you like, because we're not sort of kind of captured. We have a leadership that's spread across for-profit organizations and non-profits, but sharing that same ethos and ethics, and an extensive number of liaisons. And I've just brought up the healthcare ones there that are of specific mention here, and we have relationships with all of those folks. If you're wondering what Kantara is, well, Kantara is actually a sort of a Kiswahili come Arabic word for wooden bridge, and it was actually provided to Kantara. As many of you may know of Nat Sakamura. He's the chair of the OpenID Foundation, already mentioned by Louis, and he was on the board of Kantara for a number of years, and it was actually, he was the son of diplomat parents in Africa, and he was able to pick up this name and provide it to us, and we're deeply grateful for him. Thank you very much. Next slide. So if we were to be known for three things, and we've been mentioned already, you know, with user managed access, but we're here really to talk about the trust framework. Kantara as a trust framework provider has done that for a number of years now. In the FICAM program, GSA ran the Federal Identity, Credential and Access Management Program since around 2011, and Kantara has been providing third-party assurance against NIST 863 version 2 and more recently 63.3 with regards to that. And I understand that later in the day you're going to hear from David Tamashok from NIST, who will talk more about 63.3 and potentially 63 version 4 coming down the track. So that's primarily what we do. We're basically one of the only people that do that at IL2 and non-PKI levels. So from that perspective, we sort of kind of stand out a little bit. We also have other schemes, of course. So we do have the Identity Ecosystem Steering Group. Some of you will recall that coming out of the, it was a response, public-private sector response from the Obama administration for the NSTIC, National Strategy for Trusted Identities in Cyberspace, back in the 10 years ago or so. So that's what we do. User managed access is the other thing we're known for, and Daniel's already mentioned that. Certainly we have a profile for user managed access in the OpenID Foundation where it's combined with OpenID Connect, and that's called the Health Relationship Trust HEART profile. So well worth looking at. You know, I do think there's the potential for perhaps unnecessary duplication in some of the work being done in other spaces, but certainly it's worthwhile looking at these things, comparing them, and they primarily will work together because they've all come off the same standard space, as Louis has correctly pointed out. Consent receipt is something that we did for the for GDPR back in the 2015-16 area, when we knew that that was coming up, and it's effectively quite a simple set of fields really for consent to help with notice as well, and it's really about it's now annexed into an ISO standard, online privacy notices and consent. These fields allow for interoperability and a far better way in which to transfer, or if you like, those consents literally from the processor back to you know, the user's digital wallet or whatever it might be. Next slide, please. So to give you a sense of where Kantara fits on this, certainly one of the notions that is being talked about, of course, in this particular forum is going to be, you know, the unique patient identifier, unique health identifier. From Kantara's perspective, really, as we know from our own lives, you know, we have more than one identifier. We have a plethora of identifiers, and not only digitally, but also in plastic and so on. And they all are contextual to a lesser or greater degree. So they have different sets of attributes that, that form them as their background. So we've got to think about that quite carefully, and whether we really do need yet another identifier, or whether some of the identifiers that we already hold, provided they're assured correctly and to a high standard, can be reused in a healthcare scenario. That's a thought that's worthwhile pondering on. Next slide. So to give you a sense of where Kantara's work in identity assurance fits, I'm trying to put it onto, you know, a forum, if you like, onto this continuum of discussion that's going to be today, where you've got patient record matching, you know, at one level, at one end, if you like, and this notion of the unique healthcare identifier on the other. Identity assurance really isn't on that continuum. It's more, I'm trying to show this, if you can see, as a kind of a 3D model. It's sort of kind of veering towards the right, but it's but identity assurance is really a thing in of itself, and it certainly supports both ends of this continuum here, that's for sure. But certainly there are other vectors as well, and I'm thinking of one from FAST. The FAST task force has a wonderful slide that starts with patient matching moving up into a sort of an arrow that moves up towards federation and SSI, user-centric identity, user self-sovereign identity. And to an extent, really, Kantara's more at the upper end there. It certainly sees federation as the next, certainly the place to be. But we want to be able to be ready for SSI and that agency that consumers want to have over their personal information and identity information, to be able to quite seamlessly and progressively switch over to that. So we're certainly at that end of the spectrum. And also, I think, I've quoted here Ramesh Krishnapali from, who actually some of you may know was from the founded the FIDO Alliance. And I was on a call with him the other week because he's now, his new gig is the Decentralized Identity Alliance. And he said this, most solutions are equipped with basic security and privacy, but what's missing is trustability and accountability. There's no traceability. Exactly right. And that's really where trust frameworks come into their own. That's really what they're doing, is they're adding those things that are missing. Next slide, please. So looking at identity assurance and identity proofing and so on, there are multiple solutions, and we applaud them all. This, healthcare should be, an area where, there is competition, and that folks, that promotes innovation, and we definitely need that. But what we do need is to make sure that they're assured to one standard. So we've got one level playing field at which to judge them, if you like. And of course, NIST, ONC's support of 863.3 and TEFCA and so on is a classic case in point. So, I've generalized this example here. Folks in the Kantara Health Identity Assurance Working Group have done that, along with FHIR. So you can basically see that they all follow a fairly familiar pattern, as you can see these days, about taking the selfie and so on. And while that's absolutely fine, there's actually nuances between whether in fact they're secure enough, because the real potential issue here is the binding of that identity with the attributes to actually make a bound nicely and robustly to the credential. Otherwise, you can't really go on with this process. So it's quite important to really focus on the binding of the identity to the credential in a very secure and robust way. And as we've said, there may be other, ways of doing the image of the government issued ID, coming down the track with, ISO compliant MDLs and attribute authorities. Should federal government be able to stand in the market exposing identity information authoritatively, with users' consent, of course. Next slide, please. So mobile authentication is very, is similar. It's using the other part of 863.3, the 63B for authentication assurance level. And here's an example of using a QR code and so on. But the same ethos applies, that you can have multiple solutions doing authentication, but they need to be assured against one standard. Otherwise, you're not going to get that consistency of implementation and that consistency of trustworthiness that you need to move across. So next slide. So if you imagine when you've identity proofed and bound that identity to a credential in a mobile smartphone, you've effectively got a number of use cases where the mobile can be, the smartphone can be used as an authenticator in action. And we give some examples here about this, how the way this works. Just next slide, please. Well, I just want to finish these last few slides on a thought piece that Kantara is working on. We've talked a little bit about 63A, you know, the identity assurance level, that identity proofing, and then 63B binding that to a credential on the mobile device as well, so that you actually create a robust mobile authenticator. But one of the things that's missing there is really the assurance around the app. How secure is the app? And Louis actually, you know, started to look at this in the previous block. It's an area that Kantara has been looking at as well, and having some sort of structure around doing conformance around the robustness of the healthcare app used on a mobile phone. So next slide, please, to give us a sense of where that goes. So these were the sort of the benefits, and some folks who know of you know, the old factors, the something you know, something you have, something you are. Well, there are sort of a difference. We're proposing a different set of factors, sort of kind of related, but nonetheless different in terms of what would be the case for certainly a user with an authentication. With a mobile authenticator, and so that app has got to have different sets of factors to operate with it. And of course we have user consent where data needs to be moved, but simply, you know, a reference, a hash, whatever it's going to be, to an authoritative source to let that release that data to the appropriate relying party. So in the sense that there are a number of different benefits about bringing not only the identity proofing side with the authentication side together with the assurance around the app to make this viable. Next slide, please. And so, you know, this final slide here really to give you a sense of where mobile identity in the smartphone more specifically supports patient-centric design. It is important though, when we think about this, is that, you know, it's a channel apart from anything else, and the business process as it actually has got to be omni-channel, so that folks that you know, don't have a smartphone for whatever reason can still participate and be not disadvantaged in any way by doing that, by, you know, having the same process sitting for over-the-counter and agents and so on, other ways to do that. But certainly in mobile identity, there's certainly a number of opportunities that we can see that actually take us to a more modern, I think more user accepting space than we currently are. And I think one of the first things that was brought up in the privacy and security block was the fact that the data is moving around without the user actually having any knowledge about who's got what for when and for why. And so we've got to really move past that and bring the user into the center of the transaction. And the last slide is my final, I think. Thank you so much, everyone. It's really been a pleasure to share Kantara's views and these things with you. We look forward to seeing as many of you as possible sitting on our working groups, costs nothing to do, and participating also in the trust framework if you're a solution provider. Thank you very much indeed.
Thank you, Colin. That was excellent. We're going to move on with the trust framework discussion, and I'd like to introduce Dave Castle, the Executive Director of Care Quality, and David Pike, Senior Interoperability and Standards Consultant for Ready Computing.
Great. Thanks, Carmen. So we're going to continue the discussion on the trust framework front. As Colin mentioned, trust frameworks come in a number of different flavors, and what we'll get at here with Care Quality and ultimately the recognized coordinating entity under the TEFCA ecosystem is a little bit of a different view on trust frameworks, and hopefully we'll show how all of these different elements can come together. I will definitely be speaking at a much higher technical level than the details that folks have been getting into in some of the previous presentations. And ultimately with the trust framework,
at the level at which care quality approaches it, it almost doesn't matter within reason what exact approaches and techniques are used. The role of the trust framework is to make sure that there is consistency and predictability, uniformity, understanding of policy, the application of guardrails around whatever particular solution is chosen, rather than getting into the details of the solution itself. So with that background, a little bit more first, trying to advance the slides myself. You can go to the next slide. A little bit more on care quality, its role in the industry and its role within the TEFCA ecosystem. So care quality is a trust framework that specifically links together individual health information networks into a national interoperability ecosystem. And if that sounds a bit like what the TEFCA ecosystem itself is intended to look like, I think that's correct. Care quality, it can be looked at in some ways as a private sector predecessor of TEFCA, and that TEFCA will then build on that same concept and really expand it out compared to where care quality is able to operate today. And in part because of the experience we have in implementing something that is conceptually like TEFCA, care quality is a subrecipient of the Sequoia Project's cooperative agreement with ONC to serve as the recognized coordinating entity for TEFCA. And specifically what we're doing there is, primarily focused on the technical specifications first for how exchange will work between the participating networks in the TEFCA ecosystem, or QHINs, as they're called in that context, Qualified Health Information Networks, as well as the operational processes that go into the onboarding of QHINs, the ongoing monitoring, generally making the TEFCA ecosystem actually work in practice. So as just a little bit of further background on TEFCA, I know many of you are probably familiar with it, but just by way of background, the idea is that there would be a common agreement, a contract that each of these qualified health information networks would sign that lays out the rights and obligations that they have with respect to the other participants in this ecosystem, and generally allows everyone across the boards to know that exchange is occurring under a common set of rules so that they can understand what their rights and obligations are, and they also, more importantly in some ways, know what the rights and obligations are of others so that they have predictability and trust. They know that things are contractually enforced. They have a safety net, if you will, in the sense that there's legal enforcement rights that they have on other participants who do break the rules. And those rules are well known so that you can develop your policies and procedures with those in mind, and understanding that you will generally be able to trust the other participants and what is happening in this ecosystem in general. All right, so let's go ahead to the next slide. I'm not going to dwell on this. This is mainly here for the reference of those who might be looking at these slides outside the context of this webinar. But I do think that it's worth looking at the concept at the bottom there, that the general approach that we're taking with patient identity and patient matching within an interoperability context that relies on patient demographics, if it's not literally an asymptotic curve, it definitely is pretty close to one, where at some point, and we're not necessarily at this point yet, but at some point there's a huge amount of investment in time and effort and resources that could be put into trying to improve patient matching via basic demographics. And all of that effort and expense is going to result in only very minimal and incremental improvement in what we're actually seeing in terms of matching accuracy and the ability to correctly identify patients. And I don't think that this is necessarily news to anyone, but I think it's just worth pointing out that we need something different. And there have been, I didn't have the opportunity to join from the beginning, but I've certainly heard some of the previous few presentations here, and I think there's general understanding that we need to do something different. And would certainly agree with that. Dave Pike, anything you wanted to add here on the basic challenge?
I think you've really covered it. I mean, working from matching data, working from matching even biometric identifiers has its limits. And we've done a lot of work, and there's been a lot of time put into making EMPI systems better and faster and stronger. But eventually you get to the point where you can't match everyone perfectly. And at that point, you start having to deal with the issues that come up, the privacy and security issues that result from improper matching and improper data. And I think that's something that a trust framework working on a national level is going to hit every day, is just how, where the matches miss and possible breaches that occur from that. So I think that's it.
Great. All right, let's jump on to the next slide. So I did, I don't know how much people are explicitly addressing the construct of a sort of federally administered brute force, if you will, national health ID. You do often hear such an ID proposed as a solution for the patient identity challenges that were outlined on the previous slide. And there's a reason for that. I mean, it is highly likely that such an ID, if properly implemented and if enjoying, I'd say, at least majority support from the public, would lead to significant improvements. Now, if you talk about two very big ifs there, the properly implemented is a big if, but one that we could reasonably approach together as an industry and government effort. Enjoying majority support from the public, I'll just say seems fairly improbable. If we were going to go down this route, we would obviously need to learn the lessons of the Social Security number. Louis talked about this, and others probably have as well. And sort of the same point that Louis got to, the SSN is valuable precisely because it's been so overused in too many settings and has been used for too many things. So that there are too many things tied to it. Not that your health identity isn't valuable, but it certainly is perhaps less of a target if it isn't linked into all of your financial records and all of your other personal records as well. So again, don't want to necessarily spend a ton of time here, but thought it was worth at least addressing this construct of a true national health ID. All right, so let's jump on to the next slides in the interest of time here, because this is really where we want to spend, I think, the most time. So as an alternative to that national health ID, and I think this is generally what the sessions have been getting at, there's a need to have what I'll call a voluntary adoption of a known health identity. Now, I'm focusing on a consumer, or, well, I suppose a consumer is probably the most general label here, actually knowingly, voluntarily adopting a particular health identity. Some of the other solutions have still been about ways that we can infer a consumer's identity perhaps without necessarily having them be 100% cognizant of exactly what's going on. But there is certainly a role for the consumer to be fully aware of the fact that they have a health identity and that they're choosing to adopt it and that they're able to use it in a number of different healthcare settings. And if you got to a point where this had sufficiently wide adoption, it would provide many of the benefits that a sort of federally mandated brute force photo ID issued by the government would have as well. That said, just simply throwing the concept out there, you're unlikely to get sufficiently wide adoption. There are already voluntarily adoptable identifiers and health IDs out there. I do not have one. I think most people do not have one because they are not widely applied in reality. That doesn't mean that they couldn't be or that they're bad ideas. They certainly are not. They just are not widely adopted because they're not widely useful today. So how do we drive adoption? How do we actually make such things useful? And by the way, I'm using the letters ID here, which often implies a literal number. I really mean more of a health identity, that just as others have gotten to this concept of you have maybe multiple identifiers, multiple numbers, you have biometric criteria about yourself, you have things that you know, all of these things can come together to be a validated identity. They can all be linked together under your validated identity. And the benefit there becomes the fact that this identity can then be your passport, if you will, into the health system and ease your way through a number of factors. Finally, circling around to the trust frameworks constructs, and wow, you're able to spend a lot more time talking to these slides than I gave credit for. The trust frameworks can really help drive adoption here by providing incentives, for example, by stating in the TEFCA context that thanks, John, for the humor there. In the TEFCA context, you could say that for individual access services, for example, you would be required to use a particular, perhaps Cantara certified provider of known identities, or one or a few. There are other things we can do within trust framework requirements to generally set guardrails, again, around the options for using the health identities, as well as by setting our specifications that sort of incentivize the incentivizers, if you will, and point the industry in general towards adopting a particular approach. And then finally, in the TEFCA context, there are some more literal things that we can do with the databases, the MPIs that will exist at that qualified health information network level, to link them together and possibly even link them into federal databases like those from CMS. But the other element here that I think is worth looking at is that those who are in a position to influence consumers, health plans, for example, and possibly consumer apps can certainly encourage the adoption of known health identities. And we may find that the COVID-19 immunization and containment efforts lead to further incentives to have this construct of a known health identity that is linked to a COVID status of different sorts. And I see things flashing in the comments about, show me your papers. For better or worse, and I make no judgment on that, there may be some show me your papers elements with respect to COVID at some point. And known health identities being tied into that efforts could be helpful. It could apply some policy guardrails to that construct that may still be quite scary, but that maybe becomes a little less scary if it's linked into some policy guardrails. Dave, we're running short on time, but what any last words there?
I think the big things to realize, I mean, yes, there is a lot of things about voluntary standards and voluntary identities becoming de facto standards and requirements. But the bigger thing to realize is that they will solve a lot of the problems with privacy and security by helping keep people uniquely identified, as opposed to, having people's information shared by mistake, because there isn't such a thing. And I think that's the biggest takeaway we need to look at as we look for a unique identifier to go across. Sorry, Carmen, we've stolen somebody else's time.
It's all right. You've actually taken time away from our break.
Oh, I've stolen everybody else's time.
No, it's okay. It's fine. It's certainly fine. We are on break for just about 7 to 8 minutes or so. We should tune back in. Thank you, Jennifer. Around 11:30, and then we will move on to alliances and coalitions. So stay tuned. Thanks. I know not everybody is back yet, but we're going to keep rolling because we need to stay more or less aligned with the agenda all day. I would like to introduce Jeremy Grant, who is also one of our SMEs who's been working with us on the development of the report. He is the Managing Director of Technology Business Strategy at Venable and the Public Policy Advisor for the FIDO Alliance. Jeremy?
Hey, thank you, Carmen. Good morning, everybody. Good to see many of you on screen, and it looks like there's at least a couple hundred people, 317 participants, as I'm seeing online. So glad to see so much interest and participation in this topic. As Carmen mentioned, I wear a few different hats here in DC. My day job is part of the cybersecurity and privacy team at Venable, but I've been working in that role for about 5 years now as an advisor to FIDO Alliance, helping them, among other things, with policy and government engagement. So let's hop through the slides, and I'll talk to you a little bit about the FIDO Alliance and the work that they're doing to create open standards for digital identity and authentication. Next slide. So what's FIDO? So the easiest way to think about it is that it's an open industry association with a focused mission, how to develop authentication standards, certification, and market adoption programs to help reduce the world's over-reliance on passwords. Next. And one of the ideas behind this is, when you're looking at the problem with passwords, and we'll talk to it in a minute, and authentication, for years we've been building authentication products that security weenies, of which I think I can use that term since I consider myself one, have thought were really great, but people didn't really want to use. So if you can start to click through the slides, there's a good deal of animation in here. We started with passwords, which were really the worst combination of awful security and awful usability. We moved up to, hey, let's add a second factor with something like a one-time password token, which added some more security, but the user experience, if there was anything worse than trying to figure out how to enter a 14-character password, well, let's add a second password to that experience now. So where FIDO's really been focused has been how to, improve both security as well as usability. And at FIDO's core is a set of open standards for both simpler and stronger authentication using asymmetric public key cryptography, enabling single gesture possession-based authentication, in many cases totally passwordless flows that's both more secure and easier to use. So on the next slide, we talk a little bit about just setting the stage here, what we're seeing with the credential theft lifecycle. And again, there's a lot of animation, so you can just start to click through here to set the stage. So the target for years now has been the fact that people are carrying or storing, in many cases, thousands or even tens of millions of server-side authentication credentials. Led to more than 7,000 data breaches last year, more than 15 billion exposed records in 2019. I think we've all seen the studies that health records are more valuable than pretty much everything else that's out there. Credentials are for sale on the dark web. That then leads criminals to purchase credentials and use botnets to prep attacks, basically trying to do what people call credential stuffing attacks. We've got more than 15 billion exposed usernames and passwords. Let's basically start building bots to just jam them into e-commerce sites and e-health sites and other things, to the point that we're now seeing 80 to 90% of login attempts to e-commerce sites are spoofs, which, in addition to being just a crushing volume, means all of those companies are actually spending money on computing capacity and network capacity to basically enable all of these attackers to try to guess a username and password. And up to 2% of them are successful, which is when you're dealing with millions of passwords, it's not too hard to hit some sort of a jackpot. The annual cost to businesses is $5 billion. So one of the challenges we're seeing is this is now getting beyond passwords. On the next slide, we start talking about how we're also seeing the attackers not only phish people for passwords, but phish one-time password codes or mobile push-based notifications. So here, I think most people are familiar with, classic phishing. How do you send a fake link? You trick somebody into entering their username and password, and then that, of course, is being entered into a spoof site. But if you click through, if they know that you're protecting your site with a one-time password code or an SMS code or even a push notification, the next thing you do is just, trigger them to either enter that code or push the push notification. And with that, you have been phished out of your second factor and the attacker has been logged in. So going to the next site, FIDO, breaks this credential theft cycle and prevents account takeovers. By leveraging public key cryptography, you eliminate all dependence on server-side credentials, because all that's left are a bunch of public keys that are stored in the server side that have no utility without the private key that's stored on your device or on something that's an external authenticator like a security key. You can't phish OTP codes. It stops credential stuffing attacks cold. So that's a little bit of background on sort of the technical side of FIDO. I want to talk a little bit about who's supporting it in the next slide, because I think this is one of the most important things. There's a lot of really interesting approaches to authentication. FIDO's board is now up to 42 members that are seen here. The Alliance is up to more than 250 members. And you've got major cloud and platform providers like Microsoft, Google, Apple, Amazon, Facebook, all at the table, alongside major banks like Bank of America, Wells Fargo, ING in Europe. Aetna on the healthcare side has been a pioneer here on the board and has really led some good deployments. You have most of the chip makers as well, which is really important given that you're leveraging secure hardware and devices to enable strong authentication, and a whole bunch of different security vendors as well. I don't want to leave out the payments folks, Visa, MasterCard, Amex, all there as well. So if you had to start to think about who, since no one company can solve this on its own, if you wanted to make a list of the companies that you'd want to see come together to solve this password issue, this is who'd come together. And I crossed off password on the latest slides and wrote shared secrets, in that the problem is not just passwords, but other types of multi-factor authentication that are based on things like a one-time passcode. Still a shared secret between the individual authenticating and the service provider, and we've got real challenges there as well. Scrolling through, I want to talk a little bit more about how FIDO works and where. So on the next slide, it talks about, go one more forward, how old authentication works, which is really based upon the model of I'm here and the service provider's over there. We've got a single online connection, and I'm presenting something that's a secret that they have, generally a password, but sometimes maybe a second one-time password code as well. FIDO introduces the concept of an authenticator in between those two. And if you can start to click through again, too much animation if I'm not clicking. The first step is that there's a user verification step to the authenticator to essentially activate the private key in there. Whoop, go back one. And a FIDO authenticator, whether it's a standalone security key or a smartphone or a laptop, these can all be built in. Every single app that you're logging into has got a private key. So the public key's on the other side. There's a cryptographic challenge that's issued to the authenticator. The user has to either authenticate to it with a fingerprint, or in some cases with a PIN, or just by touching it to prove presence. But that activates the cryptographic key that can sign a cryptographic challenge, which gives you a really strong layer of authentication without actually getting into making the user work too hard for it. And on the next slide, focusing a little bit on the user experience, we can finally go ahead to that one. FIDO basically lets you use what's on your device or something that you carry with you, be it your smartphone or perhaps a standalone security key, for an overall better user experience. The next slide shows how FIDO authentication is stronger, in that it's based on public key cryptography. The private keys only stay on the device, so they can't be phished or compromised. There's no server-side shared secrets. There's no third party in the protocol tracking what you're doing. If you're using biometrics, they're only matched on the device. They never leave the device, and they're generally stored in protected hardware. And there's no way to link different services or accounts in terms of where you're using FIDO authentication. So, my security key that I use on a half dozen different accounts, but none of them have any ability to track how I'm using that key any other places. And from a simpler standpoint on the next slide, it reduces reliance on complex passwords. It allows single gesture passwordless authentication, particularly on smartphones and laptops, works with most commonly used devices, allows you to have the same type of authentication being used on multiple devices, and it's fast and convenient. To talk a little bit more about FIDO, so the initial specifications and uptake were focused, if you see on the next slide, around two standards. One was what was called the Universal Second Factor, U2F spec, that was focused largely on security keys. If any of you have used Yubico, YubiKeys are one of the most common brands that are out there, but there's a whole bunch of other companies that are certified across the standard as well. And there was a separate spec called UAF, which is much more focused on native apps on smartphones. Aetna in the healthcare space, I think, is most famously eliminated passwords for a lot of their app by leveraging FIDO authentication, leveraging essentially what's built into the smartphone rather than have to have an authentication solution bolted on. So the next step where we're going with FIDO, if you go to the next slide, is what's known as the FIDO 2 specifications, which is really building off of those early successes to make FIDO a standard feature that's embedded across every browser, operating system, platform, and device, regardless of who manufactures it, and allowing you to leverage authenticators either be they built into your device or through an NFC or Bluetooth or USB transport layer, supporting any kind of biometric that can be matched on device. It's really an ability to, how do we embed this tool in, everything that we're using? So again, authentication that's really strong and easy to use is built into every device. It doesn't have to be bolted on. And, going through, I think we can skip the next slide, if you can go ahead. Just shows that the specifications in the FIDO2 world are, if you can go back one, there's two. There's one called Client to Authenticator Protocol, CTAP, which is basically focused on how an authenticator, be it a standalone key or a smartphone, can talk to the machine that's authenticating. And then there's a separate standard that's maintained in partnership with the World Wide Web Consortium called Web Authentication, which is basically a way to embed an API supporting FIDO in the browser, so that if we are trying to log in through a browser, it's built into the browser rather than the machine itself. And so in the FIDO authentication world, we see both bound authenticators, if you go to the next slide, which means an authenticator that's actually built into the chipset on a smartphone or laptop, along with roaming authenticators, which could be a security key that you carry or your phone itself that can connect with a separate computing device like your laptop using the CTAP protocol. And in both categories, you get support for both, what I would call user presence challenge. How do you just touch the authenticator to prove that there's not a bot there? But more commonly on-device biometric matching to actually verify the user directly for true two-factor authentication. The upside of what's going on with all the companies that are supporting FIDO, if you go to the next slide, is more than 2.5 billion devices can support FIDO authentication. And where we're focused now with FIDO2 is really you're starting to see the enablement, if you see on the next slide, of what I would call cross-platform deployment capabilities, meaning that if you are a big health firm, looking for a strong authentication layer as part of a broader patient identity solution. And I want to be clear, all we're focusing now is the authentication layer, not dealing with matching. We're not dealing with identity proofing, although I'll get to that in a minute. Just, how do you solve the password problem? You can now start to deploy FIDO, without having to worry about what sort of device people are using to log in. And as a good example of this, I've got a screenshot on the next slide of a tweet I posted back in April, if you can advance to it, which was something that honestly made me jump out of my seat because I wasn't expecting it. I'd gotten a new HP laptop back in April. I was on Chrome, on a Windows operating system, logging into my Gmail for the first time because I had my Gmail protected with my YubiKey. I figured, I'm going to have to get up from the couch and go get the key because I keep it on my keychain, which was in another room, except I had my iPhone in my pocket. And I had previously registered my YubiKey with my phone when I was logging into Gmail through an application called Google Smart Lock. And basically my laptop could tell that I had a FIDO authenticator now built into my iPhone, and basically sent this through the browser over Bluetooth and logged me in about half of a second. And I didn't even realize what had happened until I got the prompt, do you want to log in with the phone? And I clicked yes, and I was done. So this is really the power of standards. Again, it would be a terrible demo in that it would be over before it started. But what you're now seeing, is an Apple device, a Google browser and Google service, and a Windows device all talking to each other behind the scenes because of the standards that's in place. I think this is much more the future of what we're going to be seeing with strong authentication going forward. On the next slide, if you can click through, just talks about some of the big companies in the market that are using this, including Aetna and Cigna in the healthcare space. I also want to point out in the next slide, FIDO is backed by certification. So there's more than 700 certified products in the FIDO ecosystem that have gone through functional certification, making sure that they essentially implement authentication the way they're supposed to. We've now introduced in the last year security certification as well, where more than 100 products have gone through, where we've got different levels of security requirements, looking at how well do you protect the cryptographic key material that's being used in these authenticators. And then at the higher levels, it's validated by a third-party lab. We've also launched the first program to start certifying biometric sensors that are basically consumer-grade sensors that might be built into your smartphone or laptop. And there's about a dozen companies that have gone through there as well. That's a little bit newer, so it's still a little bit in the early days. I realize I'm short on time. I want to just hit real quickly on one other thing that FIDO's launched work on recently, if you can start to scroll through the slides, which is also looking at how you tackle remote ID verification. So, the big question there in terms of what's been driving it, if you continue to click through, has been that if you lose your authenticator, people go, well, aren't I just defaulting back to, you know, standard account recovery processes? And does that provide a gap for somebody to, say, social engineer their way around the strong authenticator? So the way we've tended to do remote identity verification and remote account recovery, if you go to the next slide, is to leverage knowledge-based questions, which frankly, you know, the best thing I can say about it is the attackers have caught up with it. As Google pointed out in a survey about a year ago, it's next to impossible to find secret questions that are both secure and memorable, to the point that a lot of the banks I work with now say if somebody answers one of these KBA quizzes too quickly or too accurately, it's probably a good sign that, you know, it's a bot who already has the answers as opposed to a real person at the end of the transaction. So where FIDO's focusing, just as they've shifted authentication from knowledge-based to possession-based, on the next slide, is how can we start to shift account recovery and remote identity proofing from knowledge-based to possession-based? There's been a whole gaggle of new companies that have popped up over the last 4 or 5 years that are focused on how can they get you to take, say, a picture of your driver's license or passport, use some machine learning to authenticate whether it's real or not, then perhaps take a selfie and match the photo that you just took to the picture on the device. And it's really promising in that it's a way to do something that's maybe, you know, better user experience and a little bit more, you know, a little bit better security than KBA. The problem is that there's about 30 companies that do it. Only a half dozen, from what I've seen, do it reliably well. And every time somebody wants to implement this solution, they've got to figure out their own way to do testing. So a bunch of companies who are actually the big service providers asked FIDO, can you build a certification program to come up with performance specifications to how to actually measure outcomes of how well these different tools work, and then set up some independent labs to test them. And so that work has been launched a few months ago. It's ongoing right now. So this is sort of a preview of something that's coming soon, which may be helpful to be used in the health ecosystem, but it's unlike the FIDO authentication that's there and ready to use today. This is a preview of what's coming next. And I'll stop there, knowing that we're short on time and there's others waiting to go, but thanks very much.
Thank you so much, Barry. That was awesome. And last presentation before lunchtime, I am happy to introduce Tom Leary, who is Vice President of Government Relations at HIMSS, and Meryl Bloom-Rosen, the Senior Director of Federal Affairs at Premier Healthcare Alliance. They are here representing Patient ID Now. The floor is yours.
Thank you so much. If you could go to the next slide. Great, thank you. So thanks very much to Carmen and the ONC and your colleagues for inviting us to give you an overview of the Patient ID Now Coalition. And I'm delighted to co-present with Tom Leary. What we'd like to address today is the problem, the elephant in the room, which is how to accurately identify patients and match patients to their data. Ideally, that would be to ensure that our EHRs contain only our information and that it's all of the information and it's reliable. I'm going to do a helicopter ride over the Patient ID Now Coalition and let you know who we are and the diversity of our members. We're going to raise some of the issues and challenges confronting the ecosystem and then offer you some recommendations coming from this collaboration. Next slide, please. So what I'd like to do is let you know that the Patient ID Now Coalition is a group of diverse stakeholders across the healthcare ecosystem. We are committed to advancing the development and implementation of a nationwide patient identification strategy. We are seeking the repeal of the appropriations ban that was actually mentioned by Catherine early on in today's meeting. We'll talk a little bit more about that. The coalition is comprised of people like myself and Tom and others who work for and with a variety of organizations. I'll show you on the next few slides who we are. We've been working together for years. Some of us more years than we care to count, maybe as way before HIPAA, let's put it that way. Right now, we're more than 30 organizations and growing. We formalized our collective interests and collaborative efforts into this coalition in May of this year. What's important to note is that we do not have a specific solution, technology, tool, or approach in mind. What we're seeking, as I said, first and foremost, is the development and implementation, finally, of a patient ID strategy. And getting back to what Catherine mentioned early on, is the requirements within HIPAA to address patient identity, but in fact, there's a history of multiple legislative actions that have prevented this from happening. Next slide, please. On the next slide, this is the group of 6 founders of the Patient ID Now Coalition. It's, as you can see, we are a group that represents diverse interests, providers and health IT professionals and clinicians. Next slide, please. On the next 2 slides, what you'll see is the growing list of organizations who have joined us. Basically, next slide, please. You can see it cuts across multitude of interests and stakeholders across representing the continuum of care and concerns about patient identity and matching. What I'd like to also do, next slide, please. I would like to let you know in the back of our slide deck, or towards the end, what you'll see is an appendix. And in that appendix, we've identified a timeline that goes back to at least 1996. As Catherine mentioned, 1996, for those of us that were in the field and practicing in this space, is the HIPAA legislation. And in the HIPAA legislation, there was requirements to address, among other things, a patient identifier as well as a provider identifier. But you'll see in the history that since 1996, there's been an assortment of additional legislation, notwithstanding and not specific, but there was HITAC and there was the Medicare Access and Chip Reauthorization Act, and then there was the 21st Century Cures Act. So what we believe is that while there has been an enormous amount of time spent thinking about HIPAA, since 1996, there have been an assortment of pieces of legislation. What is critical to think about is that lots has changed since 1996, both in terms of care delivery, payment and quality initiatives, but most, and the technologies, approaches, tools, techniques, we've heard a lot of them already today in terms of trying to solve the patient matching and identification challenge. Why are we still talking about this after 20 plus years? So what I'd like to do is pull out for you some of the basic considerations, and then Tom is going to do a deeper dive in terms of what is happening today and what we are suggesting and recommending. So this slide gives a basic overview for those of you who are newer to the patient identity and matching challenge and concept. You can see in this example, which happens to come out of a GAO report, but certainly it's not specific to this GAO report. This slide identifies a number of policies, principles, and basic roll up your sleeve data quality issues in terms of matching a person to his or her data and what types of idiosyncratic things could pop up that prevents that from happening. Tom and I sort of joked with each other that generally speaking, I have not confronted a lot of challenges in my data being matched. There aren't too many Meryl Bloomrosens on the planet. If you meet someone other than me, please let me know. I'd like to meet my twin. But in Tom's case, he has in fact noted that just in the, I guess, the Virginia county that he lives, there are a number of Tom Learys. And the issue here is very basic in terms of how to know that Tom Leary is Tom Leary. The next slide, please. Thank you. This slide is to remind us about an anecdote of some data that actually permeates multiple reports, multiple press releases, multiple journal articles and newspaper articles about why we have this conundrum. And this goes back to 2011, at least the data does. And it identifies for you a challenge that occurred in Harris County, Texas, in the Department of Health, It talks about how many times within their database of 3.5 million patients, how many patients shared the same first and last names, how many patients also shared first, last names, and date of birth. And in the case of one particular name, Maria Garcia, they talked about how many Maria Garcias were in the database, and in fact, how many of them also shared the same birth date. Next slide. Trying to break this down for you in terms of very concrete examples. This is my summer reading list. Tom and I reviewed these. I don't want to say we read them all word for word, but my main point here, our main point here is the issues permeate going back to 1996 and 1997. Many government agencies, many private sector agencies have tried to address the challenge, and there have been many suggestions on how to address the problem. We are calling for an amalgamation, if you will, of the lessons learned and best practices that have been proposed previously, as well as those from today's meeting, so we can take some action. Please go ahead to the next slide. This is a quote from the first report that I found that was done by the National Committee on Vital and Health Statistics, identifying the need for patient identifiers. I think it's important to note it wasn't necessarily talking about a unique patient identifier, but if we are still talking and having the same conversations as we've been having since 1997, it seems that the time is right, the stars are aligned, whatever we'd like to say, given the multitude of increasing data from diverse data sources that are coming upon us, the need for interoperability and to take care of patients, that the timing is ripe for us to move forward. I'm going to turn this over to Tom.
Thanks, Marilyn. Next slide, please. And I will have to say that, you know, when, as you'll see, when I got started in this and HIMSS got started in this, our first report that was on the previous slide of 2009 was at the request of several organizations that said, you know, at CMS, they're starting to worry about dual eligibles. And you know, they've got 400 people at CMS who simply track patients and try to deconflict and, you know, incomplete data, et cetera. So it really, as we've heard from many speakers today, it comes down to the quality of care and patient safety. You know, as our group, and the reason why HIMSS has gotten involved in the Patient ID Now Coalition is that you know, we can't wait any longer. You know, the information that we're sharing today, the information that's being discussed today, and the potential solutions are all out there because of the improper, incomplete, or inaccurate patient identification. There's increased chance of misdiagnosis. You know, I happened to be talking to some family members last night, and you know, it's not just the Tom Larrys of this world, but it's the Kathleen M's and the Kathleen A. Larrys of this world that, you know, that's my sister and my mother have share the same name except for a middle initial. And, you know, the number of times they've gone into different doctors and had to say, no, I'm not the, you know, I'm not the mother, I'm the daughter. The number of times that my brother, who shares the same name as my father, has had to explain that he's not Medicare eligible, but that, you know, you know, it's just a perfect example of why we need better solutions. You know, as we all know, you know, stifling, it stifles and impedes interoperability, innovation, and improvements in care. Some of the solutions that we heard today, just from our colleagues at FIDO, is, you know, I've experienced that just as recently as yesterday, when, you know, with very similar you know, laptop and iPhone configurations that Jeremy described. You know, so it's all really a great opportunity for us. Next slide, please. And you know, and then we can't be. I'm here in my office. I'm the only person in the office today, and it's it's the second time I've been in our office since March, and we're all experiencing COVID from different perspectives. And when it comes down to the impact on patient identification, it's again, talking to individuals at the Council of State and Territorial Epidemiologists and staff spending hours searching databases. One public health nurse that I know very well, my younger sister, again talking last night. My younger sister Susan is a public health nurse for two communities in our home area, and the amount of misinformation, where nationwide somewhere between 70 and 80% of some of the tests, the COVID-19 tests that are coming back, don't have accurate information, a lot of missing information. She then literally uses lots of Google searches to be able to then properly identify an individual, then get them on the phone. Reports are coming in as duplicate, going to the wrong health departments. We can talk about patient, in the state of Georgia, a great example of newborn screening information goes back to the hospital where the baby was born, but 50% of the children their first encounter with the healthcare system beyond the current beyond the actual birth is at a family physician or pediatrician's office. So really going to the wrong place, it's a great concern, and COVID-19 has absolutely highlighted that. Next slide, please. I mean, we're also, as I think this is just further example of heightened awareness of patient identification, matching challenges. We're poorly matched data, public health systems increasingly rely on EHR data, but then having to turn to antiquated solutions and going back and forth between faxes and EHRs. Absolutely, there's a requirement for interoperability. Having the incorrect data has negative impacts on timeliness of alerting the patient, timeliness of the public health response. Next slide. As we'll hear later today, I don't want to steal Jennifer Stoll's thunder here, but as we'll hear from her later today, OCHIN is one example of a nonprofit that interacts with a lot of underserved communities. And the exacerbation of health disparities during COVID-19 in these underserved communities has been absolutely highlighted by the fact that amongst the Black or African American patients make up 13% of their patient population, but 21% of the duplicates. Hispanic or Latino patients, again, 21% of the population, but 35% of the duplicates. And homeless, it's increasing challenge for OCHIN, and as we've talked to some of our other members across the Patient ID Now Coalition, it's 4.3% of OCHIN patients, but 12% of duplicates, nearly 3 times the expected rate. And finally, for migrant population, it's 3.6% of the duplicates, where they're only 2.1% of the patients. And this is just one healthcare organization. Others are starting to learn from OCHIN and starting to look at these issues, what the real impact is on health disparities in underserved. Next slide. So as we, as the frightening thing about is we're preparing for a vaccine. I happened to go on the CDC website to see the number of large-scale immunization programs that are currently in place, or that depend on accurate patient information, particularly if the vaccines are required multiple doses. Something is, shingles, Hep A, MMR are all examples of vaccines that already require more than one dose. If the COVID-19 vaccine requires more than one dose, making sure that we know who has had the disease, who's been vaccinated, what are the patient outcomes, and where the stockpile is for distribution, to make sure that as we know more about the individuals who need the vaccine, and are able to identify people that still need a first, second, X number of dose, that all of that needs to be taken into consideration. Next slide, please. So, we've been asked also, what about the persistent perceived privacy issues? What about the creation of a centralized repository, and what kind of impact it'll have on individuals? What about this potential of centralized database to be used for discriminatory purposes, or for more than just for healthcare? Or healthcare is only one area where the data can be used. And of course, the issue around HIPAA requirements for privacy. I think it's real important that for our coalition to be able to point out, next slide, please, that that it's really the inverse privacy challenges. The current system has created a situation where individuals must repetitively disclose their individual identification. They inadvertently, systems will have the wrong information about the wrong patient in a record, or they'll disclose information about a patient to the wrong people. They'll share information about a patient who has been directed not to have their information disclosed. All of those are further exacerbated by not having a true approach to patient identification. Next slide, please. So what are we really calling for? A national patient identification strategy, because of all the things that we've outlined and the narrow interpretation of Section 510 of labor HHS appropriations, has caused us to have an imbalance in the way healthcare is provided. What we need is a rebalancing of the patient privacy and safety. We have countless stories of wrong site surgery, wrong patient getting the wrong care, getting the care. We recognize that the ban was actually put in place when HIPAA had been passed. HIPAA regulations were still 2 years off when the ban began. So the idea of that high-tech and 21st century cures and MACRA and all of the different pieces of legislation that Merrill has identified, they've all built on the idea of having interoperable healthcare. We're truly not going to get to interoperable healthcare unless we have a national strategy for patient identification. Next slide. So what it comes down to is that we're involved, AMS is involved with our members, with the other members of the Patient ID Now Coalition, because we can't wait any longer. My son was 2 when I started with this on this topic. He went to college last week. My hair was full. It's not anymore. What we really need to get active. We need to remove the ban. HHS having HHS as an equal partner at the table with the healthcare community. We need to prioritize the accuracy of patient identification and matching with respect to the urgent public health emergency, as well as the national vision for interoperability and the ability to share information across jurisdictions, across communities. We recommend that that there are privacy concerns, but that HIPAA has done an admirable job over the years, as well as the enhancements to HIPAA have done an admirable job of protecting patients' data. And finally, we need to develop a national patient identification strategy that will improve patient matching to support secure information sharing, improve the quality of the data and the quality of the care, and effective and efficient patient care. And finally, above all, that patient safety remains paramount. I'll just say that as we look to the solutions and we, what becomes of a national patient identification strategy, the idea of our coalition is remove the ban, get to that strategy, and remain solution agnostic. Can't say it enough. You know, Meryl started our presentation with that solution agnostic, so that we could embrace all of the different creative ways that individuals and organizations are thinking of solving this issue, but we need a national strategy. Next slide, please. So that's us. That's the Patient ID Now Coalition. Our recommendations are clear here today, as well as just a call for more. We need more organizations to be part of our work. So whether you email Meryl or myself or see the website, we'd love to have more involvement, and we appreciate the time, Carmen, and you know, let's get to a national solution. Thank you.
Thank you both. Thank you, Meryl and Tom. We are now on lunch break, so we will tune back in right at 1 p.m. Eastern. We encourage everybody to join back as soon as you're able. We appreciate all of the input that we've received so far this morning, and we'll see you this afternoon. Thanks. Good afternoon, everybody. We're coming back from lunch at this time. This morning we covered privacy and security, trust frameworks, alliances, and coalitions. And this afternoon we will focus on digital identity, operations, matching within and between systems, operations and governance, research, innovation, and equity. And we're going to kick off the standards discussion, especially for digital identity, with David Tomaszak from NIST. David, do you want to take it away?
Thank you, Carmen. And I'd like to thank the ONC for inviting me here to speak this afternoon on digital identity management and the NIST Digital Identity Guidelines. Go to slide 2, please. For the topics for this session, I'm going to cover the state of digital identity management today, NIST's role in information security and digital identity management. I'll give a very high-level overview of NIST's special publication, 863, Revision 3, the Digital Identity Guidelines. I'll go into a little bit of discussion on how the guidelines address authenticators and identifiers. I'll identify the password problem that we have today and cover what is multi-factor authentication and what about biometrics. Slide 3, please. So for the state of digital identity management today, digital identity management presents numerous challenges for identity proofing and authentication over open networks, principally by remote processes. There are multiple opportunities for impersonation and other attacks that can lead to fraudulent claims of the subject's digital identity. What we see today in trends is increased consumer and commercial demand for more robust identity authentication in order to be able to defend against increasing sophistication of attacks. We see globally increased statutory and regulatory demand for data privacy and data and personal information protections over open networks and for data at rest. We see increased demand for multi-factor authentication, and I'll cover that in this session. We see a rise in biometric authentication, given the convenience for consumers and for users, but I also want to put that into perspective. And we see the demise of knowledge-based verification. And by this, I also mean knowledge-based authentication, which are basically synonymous. Everyone should be familiar with knowledge-based verification processes where the user is queried for what used to be secrets. Elementary school attended, first car owned, street you grew up on, mother's maiden name. Due to data breaches, due to social media, these are not secrets any longer. We might consider these private information, but they certainly aren't secrets, and it's certainly proven to be vulnerable to attacks, as we've seen in recent years. Over 700,000 IRS attacks were successfully made using knowledge-based verification. And then there's COVID-19 pandemic, which is causing processes and transactions that used to be in person to be conducted online and conducted remotely, which is only accelerating these trends and increasing the focus on these trends, and the problem that just won't go away: compromised passwords. Next slide, please. So NIST's role in information security. I'm gonna bring up the Federal Information Security Management Act, modernized and amended in 2014, which addresses the importance of information security, both to the economic security as well as the national security interests of the U.S. The Act, or FISMA, requires all federal agencies to implement and annually review security of information systems and report on the effectiveness of the controls that are in place over information systems and information security. Now, FISMA as a law is written pretty high level, but assigns NIST the responsibility to provide specific guidelines, controls, and requirements for how information system security is to be conducted across the federal government. NIST IT Laboratories, my organization, publishes security guidelines, standards, and frameworks to implement FISMA. We do that through special publications in the 800 XXX series. So if you see NIST publications, special publications, 800, 53, 63 are examples. These are standards to implement FISMA for the federal government. For the federal government, special publications are mandatory standards. However, the special publications and the controls and the standards contained in those special publications can be adopted by non-federal organizations or international bodies, and have been. Next slide, please. So, special publication 863, revision 3, obviously one of the information system security guidelines and implementation requirements for FISMA, also called the Digital Identity Guidelines. The Digital Identity Guidelines consist of 4 volumes, which address applying the NIST risk management framework to digital identity management. The 4 volumes are in volumes A, B, and C. Volume 63A addresses identity proofing and enrollment into an identity system. And these represent the processes for assuring that an individual is who they claim to be and enrolling those individuals in an identity system. Let me just mention why that's important. Identity proofing is expensive for service providers, as well as being very inconvenient for users. Enrolling individuals in an identity system allow individuals to maintain an account, a registration account, where authenticators and identifiers and credentials can be registered to that account so they don't need to be identity proofed every time they want to access an online service. They can use the authenticators that have been registered to their account for sign-on and to be able to access protected resources, thereby saving the need for additional identity proofing. Volume 63B deals with authentication and authenticator lifecycle management. And authentication is the process by which a user that's been registered into an identity system and is attempting to access an online protected resource proves ownership over an authenticator and the secrets associated with that authenticator in order to gain access. 863 Volume C addresses federation and federation assertions. And federation represents the processes for asserting authentication status as well as attribute or other information across domains. We will not go into more discussion on federation in this discussion this morning, but all three of these volumes present the requirements under the risk management framework of NIST, which means there are established controls at 3 assurance levels, low, moderate, and high, for each of those volumes. 63A, identity proofing, 63B, authentication, and for 63C, federation. Next slide, please. I'll admit, it's pretty tough wading through 4 volumes of the standard. So what you see on the screen now is reference to our Identity and Access Management Resource Center. You see highlighted the URL. There you'll find resources on identity management projects that IT Laboratories at NIST is undertaking. If you look at projects, you can go to Special Publication 863.3 and pull up the resources that are available there for the digital identity guidelines. I want to mention 2 of those resources in this session this morning. One, the implementation resources. The implementation resources cover volumes 63A, 63B, and 63C, and provide non-normative informational guidance on the implementation as well as the potential assessment of topic areas that are addressed in A, B, and C. There are direct links within the implementation resources that link directly to the special publication text to facilitate understanding as well as the implementation requirements in non-normative text. I also want to mention the conformance criteria. The conformance criteria address all normative requirements and controls in 63A and B at assurance levels 2 and 3, moderate and high assurance levels. And these are non-normative informational guidance on how to implement the controls, understanding the requirements for the controls, and assessing conformance to the controls. Remember I said it's a government-wide requirement under FSMA that all federal agencies are responsible for assessing their implementations of special publications and reporting on their conformance on an annual basis. Next slide, please. So 63.3 does address identifiers and authenticators, and a bit about authenticators. Authentication is the process for verifying the identity of the user through verifying their possession of an authenticator and a secret that has been registered to their identity account in an identity system. Authentication processes will always include an authenticator. and an identifier. And identifiers are used to identify the subscriber to the online system. This might be a username, although we're not fond of it. It could be a social security number, attribute information, registration information, which is used to identify that subscriber to the online service provider. Identifiers must be unique for the identity system for that specific domain. Authenticators is or always contains a secret. Authenticators can be a PIN and password, one-time password, a secret code, cryptographic keys are all examples of authenticators, and the secrets that are contained by an authenticator that are used in authentication processes. Special Publication 863B identifies 9 types of permitted authenticators for use in the federal government and describes their use and the controls for their use. Identifiers may be pseudonymous, but are not secret. So no matter what we think about social security numbers, they're not a secret. And identifiers, because they're not a secret, cannot be used for authentication purposes or for identity proofing. They're not secrets for either purposes. Next slide, please. The world has a password problem that must be fixed. Jeremy Grant spoke to this. 80% of the hacking-related data breaches result from compromised passwords. You see, even today, the most commonly used password for a 6-digit password is still 123456, and about 3/4 of the people use the same passwords for multiple sites. This needs to be addressed. Next slide, please. Well, the answer today is multi-factor authentication, also called two-step authentication or two-factor authentication. Multi-factor requires 2 or more authentication factors for verification purposes and adds a second step to initial authentication by requiring additional factors. And you see the 3 factors for authentication in the box. Possession, something you have, can be a mobile phone, which contains cryptographic key, for example. Knowledge, which would be restricted to PIN or password, something that you know but you don't share. And something that you are, a fingerprint, a facial image. Multi-factor authentication requires 2 or more of the authentication factors to be incorporated into the authentication process so that stolen and compromised PIN and password aren't enough for attackers to gain access and control to a user's account. They would have to gain access to their devices as well, increasing the level of security. So if biometrics are an authentication factor, what else about biometrics do the digital identity guidelines say? If you can go to the next slide. Biometric comparison is a very convenient way for users to authenticate themselves, particularly to devices that will allow for biometric comparison. Biometric comparisons, something that you are, fingerprints, facial image, iris scan, or something that you do, behavioral characteristics like keyboard patterns, voice patterns. However, biometric characteristics are not a secret, and the digital identity guidelines do not allow them to be used for single-factor authentication, but can be used as a factor in multi-factor authentication. And 2 more considerations about about, or limitations about use of biometrics. Biometrics themselves can't be revoked. If your fingerprint gets compromised, you can't change it. You can't revoke it. And by definition, biometric comparison and matching is probabilistic based on approval rates and error rates, which means errors are built into the authentication process for biometrics. Last slide, please. Any questions that you have? We don't have time in the session, but any questions that you have, you can send to the alias on the board, dig-comments@nist.gov. We take comments and questions very seriously, and we respond to them all. So I want to thank again ONC for inviting me to come and talk to you this afternoon.
I was on mute. Thank you so much, David. We really appreciate it. And next up, I'd like to introduce Rosemarie Salai, who is a Senior Technical Advisor and Lead IT Security Specialist here at ONC. Rosemarie, there she is. I think you're still on mute. One more mute.
Mute. There we go. Yes, thanks everyone for attending ONC's session on patient matching. I think we're all excited to hear from everyone. I've learned a lot today, and I just want to say that a lot of what I will be talking about has already been presented, so I'll keep it short. I think we all know that credentials are important in patient matching, and the whole concept of having a unique identifier is important in healthcare. However, just simply having a national patient identifier per person, per consumer, will not really solve the problem. And that's why up and coming meaningful credentials are important. Next slide, please. So before I start, and really I would sum it up, a lot of speakers have covered decentralized identifiers. I just want to mention that with a social security number or any other national identifier, if it doesn't meet digital credential standards, I do not see how it would scale. And that's simply because if social security is hacked, your number is essentially hacked and you have a lot of recovery that needs to get done. So when we talk of a unique national patient identifier, it sort of doesn't solve the problem because it needs to be more in a decentralized format. So when it's lost or stolen, you can have another decentralized identifier that is cryptographically sound. If your social security is stolen, it's pretty much your social security is stolen and it's hard to get a new one. With decentralized identifiers, you can have multiple decentralized identifiers. I will stop there and really focus on some of the things on my slide. Blockchain has been around for quite a few years. It's not yet well public in healthcare, but it does have potential. At some point, we were all looking into blockchain technology as part of the solution. And I think blockchain, when it becomes ubiquitous, it will enable and support the EMPIs that Dan talked about, EHRs, centralized record locator. And most blockchains are open source, so they can easily be used to drive their different processes and data distribution between diverse health IT systems. So with blockchain, we still have the potential of establishing trust and scaling identities and ensuring that the blockchain process is trustworthy and has rules of engagement. It's not just a technology problem, as some of the speakers mentioned, it's also a governance problem and a trust process and a standard process. The next item that I would like to talk about is verifiable credentials and decentralized identifiers to some extent. We've all heard about verifiable credentials, which are really the digital counterparts of our physical credentials today. So you have a passport or a driver's license issued by DMV, Department of Motor Vehicle, and that passport could, for example, use a blockchain to register the schema for that passport, to register what are sort of the known items that you need to validate on a blockchain what that credential looks like. The patient controls the identifier using even a smartphone and can share what is needed and as needed. And the issuing authority definitely would have to publish certain requirements on the blockchain as to what his or her identifier means, and there needs to be a circle of trust again. So the trust frameworks that Kentara talked about and a lot of Louis reference is very important in healthcare. Having a trust framework, having sort of a system to recognize what schema is being mentioned is very key. What we want to avoid in terms of identifiers is we don't want the schemas to keep proliferating. We need standards. And I think a lot of the speakers talked about having standards, and ONC is really focused on having standards so that we can have a clear way to know exactly what each identifier relates to. And I'll give an example. The driver's license in Virginia has a specific schema, last name, first name, has address, etc. In California, the driver's license has a different schema. Well, if we have multiple schemas all over the place, we're just compounding the problem that we already have even in patient matching, which everyone has a way of creating their own patient profile within the EHRs or within the EMPIs or within the DICOM, the PACS radiology systems. So I think as we progress in digital identities, we have to look at are, and we have to ensure that all participants are using similar schemas or scalable schemas that are widely acceptable. So each issuer of a digital identity is not reinventing the wheel. And next, I want to talk about self-sovereign identities, which is really going to leverage verifiable credentials and decentralized identifiers, and also blockchain technology. All those three technologies are sort of work hand in hand. They're very compatible. And so next slide, please. Thank you. And these are just some definitions. In the interest of time, I wouldn't go ahead and review why blockchain is still something we should keep monitoring, especially in healthcare. It does have a lot of potentials to really improve how we record information, how we create provenance of record. But in the interest of time, I just want to mention that it accelerates decentralized identity models by providing a web of trust. I think blockchain and distribution ledger technology can really help us get there sooner. And it's open source and it drives trust and transparency. And the idea of a longitudinal patient record, it would enable us to trust that record in terms of its accuracy, it's comprehensive, and it carries integrity. And in healthcare, we all know that your longitudinal health record, which has all your record information, is critical to ensure that you receive the right care at the right time. Next slide, please. So verifiable credentials are the heart of the self-sovereign identity. Again, the whole concept of a user controlling access to information, giving anyone access to how it should work, and allowing what should be shared to be shared. So I don't need to give you my address if all you need to do is verify my age. So the whole concept of self-sovereign identity is proliferating, and it really builds off of DIDs and verifiable credentials. It's also supported by UMA framework, the user access management framework, and it allows people to interact in the digital world with the same freedom they do in the offline world. It really allows a user to control what is shared and what is not shared, and it allows trust in the system. It's another element where trust is extremely, extremely helpful. Next slide, please. So again, I wouldn't reread all the importance of decentralized identifiers. I think we have talked about it being decentralized, not owned by one organization. There's no specific identity provider. And that's where we need to go. The whole concept, again, I keep moving away from a national patient identifier. It's the whole concept of having multiple decentralized identifiers versus one identifier that could be hacked, stolen, lost. There's a lot of future that if we can come together and build off of DIDs, I think it'll be a great a great enabler in scaling trust and scaling really how patient matching occurs. It would facilitate EMPIs, and it would really help bring the health system together in a more unified way. Again, standards are important, so DIDs have to work off specific standards as well as verifiable credentials that are built off of W3C standards. It's still being developed, so those are things that are up and coming, and we need to look into it. It's not a new technology, DIDs. I believe Louis mentioned it's like a URI, and UDAP would adopt to it pretty nicely. So I do believe that as long as the technologies are not self-created and can work together, we don't really need one unified platform. Next slide, please. Okay, so my last slide really I would like to talk about self-sovereign identities, very specifically how it works in the credit union. So I believe that we could create multiple trust frameworks for different purposes. So you don't need, initially when trust framework started, we had one major trust framework, but as we progress, we could have domain-specific trust framework, provider-specific trust frameworks, patient-specific trust frameworks. DICOM already sort of have its own trust framework. So by having specific trust framework, it allows everyone to buy in, and it allows trust and scale. CU Ledger is a consortium of federal credit unions. They're able to scale at over 118 million members today. And it's actually important because they're able to create a self-sovereign identity, a digital identity that is used within the federal credit unions among participant credit unions that are part of the CU Ledger framework. This is possible in every single domain as long as it's unique and it meets the purpose for which it's created. And it has the right governance structure, the right standards, and the right buy-in. Again, we need a sort of an overarching umbrella, and TEFCA is one of those that ONC is working on that will create a framework for others to build off of. So we don't have lots of independent agreements. But we also need to understand that the trust framework has to be unique to the needs of the participant members. So it can add value and could reduce duplication. And in terms of patient matching, it would really help to have a specific trust framework just to self-create, govern how matching is done, have the right schema, and all agree on what will be published on the blockchain, what schema needs to be used to validate a patient, how do I know patient X is really patient X. With that, I will turn it over to Carmen, and thanks for the time to really opine on this great presentation. Thank you.
Thank you, Rosemary. We're going to jump right into Alan Byers, who is president of Identity. He's also one of our SMEs. And he will be actually, there were a few questions in the chat on Real ID, which I'm going to.
Yeah, sure. I'm going to talk about a Real ID driver's license enrollment example. So next slide, please. First of all, I'd like to thank ONC for having me. I'm going to maybe kind of continue on some of the things that Dr. Louis Moss touched on and try to give a real world example of combining a lot of these different standards and guidelines into a workable solution. And so specifically, I'm going to talk about OpenID Connect, also called OIDC, the NIST 863 Digital Identity Guidelines, Real ID, which is essentially the new driver's license standard that all 50 states will be adopting, OAuth 2, which is a framework for delegating access to information like APIs, FHIR, which is what's in the ONC and CMS rules around patient access to information. So that's actually some of the health information format, and FIDO as a way to do multi-factor authentication. So what I'm going to do is just show a scenario of a COVID-19 drive-through testing site. So imagine Joe Public is coming through to have a COVID test, and this person wants to essentially get those results at some point. We're going to assume that when the test is taken, the results are going to go to some health information exchange, and that may be statewide, and this person will be able to get access to that information. I point out that most health information exchanges right now don't really have a patient logon facility at all. They weren't really stood up to have a patient-facing portal. So if organizations are looking to leverage HIEs to meet the CMS rule, the patient access rule, creating a patient logon is going to be a challenge for some organizations. But I'm going to show how we can do all of this together. Okay, next slide, please. So this is definitely a state-issued ID here of James T. Kirk. And essentially, James is coming through this drive-through COVID center, and there is a trusted agent, a person that is in processing the people taking tests, and they are trained to do the identity check. So this is a version of identity assurance verification, trying to get them to an IAL level 2. There's many vectors that can be used to achieve this, but in this particular scenario, we're doing an in-person verification. So this trusted agent essentially can look at the person and look at their ID, right? You know, they're holding up, and then they are essentially verify their identity and that the credential is valid. And then they're going to scan the barcode on the back of the ID. I want to point out that Real ID is really kind of two pieces of a guideline or standard. One of which is the process for identity verification in order to get the Real ID. So when you go to the DMV, you have to have all the right documents in order to get the Real ID stamp on your license. So that part is done at the DMV. And but the second part is the barcode itself. So the barcode on a Real ID, a lot of states adopted this format before Real ID, but now essentially it's part of the Real ID spec, is that is a PDF 417 barcode on the back. And here's an example of a scanner that can read it. Not all barcode scanners read it, but most of them. You know, buy this off of Amazon for 30, 40 bucks. And the format of which of the data in the barcode is standardized by an organization called AAMVA, which is essentially like a DMV consortium. Next slide, please. And so the agent essentially verifies the ID, and then after they're satisfied, they scan the ID, and they get a code that looks like this. This is actually what the contents of the barcode, which contains, among other things, their first name, last name, date of birth, and address. And that information can then be pulled out, and that can essentially be the seed of an enrollment, and also the ID card shown in person itself is essentially the identity assurance event to give them an IAL level 2. So next slide, please. They scan the barcode. And now James still needs to provide his a password so that he can then log in, and a mobile, an email address and a phone number so that he can be contacted. And there may be some other things like setting up a FIDO token. So at that point, he may want to add FIDO hardware to the account. So if the identity provider supported that, that would be okay. So, and then essentially, James is going to get a text message or email that says set your password, and you know, set a recovery passphrase and do other things related to your account. And now James has all his account is essentially ready to go to start accessing health information. So. Next slide, please. And so this is kind of just a view of where the patient, if you will, is identity verified. They have a core ID in OpenID Connect, which is always a field called subject, or SUB, short for subject. And that's essentially this third line here. That is you want to call that is the primary key in any OpenID Connect implementation. But it's going to be different between Google and the version that I'm showing here. But you'll see down here, it actually says identity assurance level of 2 because the ID was checked. And that person, that agent, essentially, by virtue of scanning and doing a rapid onboarding, was verifying as a trusted agent. They are who they say they are. Their account is pretty much set up. In this particular scenario, we're using something called a document claim, which is in the iGov profile for OpenID Connect. But essentially being able to add issuers and values to an identity token, such as a patient ID, a FHIR patient ID. Because when you're pulling data with FHIR, you want to pull the, you're essentially indexing everything off this patient ID. In our case, we're imagining that the Health Information Exchange has already created that and is loading that and is attaching that to the ID token. And the reason you want that to be to work that way, instead of doing a connect to the new service, try to do the patient linking and matching right now, which may or may not work or be failed. Essentially, if it's already there, it'll just work. It'll just be a very smooth user experience. But I wanted to show this last line down here where it says patient ID is 987654465. So there could be no identifiers there or many identifiers, and they could be like Andy Gregorowitz explained, privacy preserving identifiers. But the point is the ID token itself is containing one or more identifiers that can help with the patient linking and matching. Or better yet, the patient linking matching has already occurred and the resulting identifier is now like loaded on to that ID token as a claim, therefore making the data connection seamless. Next slide, please. So I want to point out that James more or less had an IAL2 credential coming in, a physical ID card with his picture on it that was state issued, right? That driver's license, that real ID. But now, since the account is created, we've essentially leveraged that driver's license to create a digital identity through an OpenID Connect implementation. So the ID token itself, which is the real meat of the OpenID Connect standard, that is what is a document, a digitally signed document that is sent down to the relying party that typically has the user's name. It may have their these different identifiers, their subject identifier, their birthday. But that ID token is that digital credential is ephemeral because essentially it just verifies the person is right there at that time, clicking I approve, or actually authenticating and logging in. OpenID Connect really is a single sign-on solution, and at that moment of sign-on, when the person is right there, this ID token is sent, and it's typically good for maybe an hour or something. It's not. It's just to prove that the person is there. But now James is all set up to access third-party services that may require IAL2. And in our scenario, we're separating the OAuth 2 resource provider, which is going to serve the FHIR data, and the OpenID Connect, essentially the identity service. So I think it makes great sense to separate identity concerns and more broadly from a particular use of grabbing health information. And the point of that is to make a reusable infrastructure that looks kind of like what they have in Estonia or Iceland, as just an example. Okay, so next slide, please. So imagine James is all set up, and then James uses Apple Health or something else, and he is authenticated, and then now he is at the point of OAuth 2 authorization to personal health information. Like, do you give this app, in our example here is Test App, do you, James, give Test App access to your data? Yes or no? This is a very long disclosure. Next slide, please. I couldn't fit it all in one slide. So that's kind of the bottom. You're basically approving that. So James clicks approve. Next slide. And now the third part, essentially the third-party app, is given an access token, an OAuth 2 access token, that is bound to that user's identity, so that then they can then make calls to get the patient data.
I'm sorry, Alan, we're going to have to move forward in the agenda. Do you want to skip to your last slide for your contact information?
Oh, sure. Yeah, the only thing I would say is that this bearer token, essentially the token, well, the patient ID is kind of irrelevant, because if you return a result for a particular patient ID that doesn't match the token, you're giving somebody the wrong information for another patient, so that would be wrong. But yeah, next slide. I think I'm basically at the end here. This is just a diagram explaining what I was showing, separating the OAuth provider from the OpenID Connect service, and that the information would be essentially coming from a FHIR source that is shown up here in the top left. I'll provide this to anyone that wants to see it later. And last slide. I just think it makes sense to keep the OAuth 2 provider, which is the FHIR data, the personal health information, as a separate service from your identity service, which hopefully is OpenID Connect, but it could be something else. And that's all. I have a link here to a document that I wrote to sort of maybe help states doing this for Medicaid, if anyone is interested. Last slide is my contact info. Thanks.
Great, thank you. And just a reminder, a recording of this session will be available on the ONC Patient Identity and Matching website for everybody's reference. So in case you missed some of the slides that we had to rush through, unfortunately, right now I would like to, so now we're gonna move into matching within and between domains. Yes, and Ryan Hess, VP of Product and Innovation, Norm Adams, Principal Master Data Scientist at SureScripts. Hi, Norm.
All right, I will kick us off. This is Ryan Hess. I am a VP at SureScripts. I do not have any cool pictures of James D. Kirk or Star Trek, so apologies for that up front. But we will talk about some interesting things that SureScripts is doing. So if you go down one slide, we'll cover a few different topic areas. I'm going to start it off by talking about SureScripts. Many of you may not know who SureScripts is. Some of you may. We are the largest health information network in the US, and I'll run through a couple of statistics on that in a moment. We work almost entirely behind the scenes. So we connect in your doctor's office. We connect that EHR to the pharmacy management system at your local CVS or Walgreens, back again to the pharmacy benefit manager, the PBM system, or the health plan system, and a few other nodes in the network. But we are really a backbone in back of all of those different systems. So you don't see our name too often. But if you go to the next slide, there is a good chance that you have heard of us. And apologies, the slide is portraying a little bit differently, so I'm going to call out a couple of the numbers here. So in the top left, the 314 million, that is the number of patients that we have in our master patient index, which means that that is the number of health plans and pharmacy benefit managers that we are connected to. And those two entities supply us information on each of the patients. So we have 314 million of the people in the United States in our master patient index supplied by either the health plan or the pharmacy benefit manager. The 1.87 million is the number of healthcare professionals that we connect to. So we connect to EHRs, long-term care systems, pharmacy systems that are representing 1.78 million healthcare professionals. So almost every healthcare professional out there in some way, shape, or form touches SureScripts on the back end. Across the middle row, the 19.15 billion transactions, that's the number of transactions that we did in 2019. So 19.15 billion transactions in 2019. We put in there the number of e-prescriptions, because often if people think of us, that is what they think of us most about, is the number of scripts that we have routed from a doctor's office to a pharmacy. But the reason why we also show that here is because you can see that it's actually now a small piece of the total transactions that we do on an annual basis. So if we go to the next slide. So as I mentioned, routing, taking the script from the doctor's office to the pharmacy is one thing that we do. This is a standard patient journey chart. So starting at the very beginning, the patient arrives at the clinic. At the end, the patient arrives at the pharmacy to pick up a script. I'm just going to call out a couple of things on this so you get a little bit of an idea of the breadth of what SureScripts is trying to do. So all the way on the left-hand side, as the patient arrives at the clinic, we do two important things. We will deliver a medication history for that patient. So we will deliver every med that that patient has picked up at a pharmacy and every med that a pharmacy or that patient has had paid for by their health plan. We take all that information, aggregate it, and send it to the provider. We will also do what's called record locator and exchange. For us, that means we go out to all the other EHRs that we are connected to, and we try and find any other health records that may be available for that patient. So those are the two things that we do upfront as the patient is arriving at the clinic. Now, if you continue on down the journey, the doctor is now writing a script. Oh, sorry, go back one slide. I'm almost done with this one. As we continue down this down the curve, the doctor now writes a script. What we then do is we identify the insurance that that patient has. So we identify the pharmacy benefit insurance the patient has, and we deliver formulary information and pricing information on that script. The last part that I'll talk about right in the middle there is if a prior authorization is required, we will do that electronically as well, with the net result being the patient picks up the script at the pharmacy. So that gives you some idea of the breadth of what we do. Now, how of what we do in terms of finding all of these information and about the patient, if we go to the next section. So if we go to the next slide on this one, and I'm going to hand it over to Norm Adams, who is going to talk about how we do our patient matching.
Okay, can you hear me? Hopefully?
Yes.
Yeah. Okay. So yeah, what I want to do is I want to share some of our, talk a little bit about our matching strategy. Let's share some lessons learned, and then finally talk about some of the our thoughts on future directions. So if we go to the next slide. Okay, so this kind of shows some of our challenges. So we were getting records from the PBMs, the pharmacies, and the EMRs. This can be up to 100 million records a day. And we want these records to be in our MPIs and searchable within 24 hours. So one of our big challenges is to get 100 million records a day into our MPIs and searchable. But once they're in there, we use those MPIs to do a real-time search and then route the request to the appropriate area, whether it's an eligibility request, then we send it off to the PBM. If it's a med history, then we go to our to the real-time prescription database. So again, the message here is that the challenges are the large number of the volume of records we have to process every day. Could we go on to the next slide? Okay, so we have an average. Our average response time is 21 milliseconds, and we have a high availability requirements. Within our MPIs, we have 313 million unique patients, and that's pretty much the entire population of the United States, almost. And we process about 18 billion matches per year. And I'm not going to say a lot about the fields we match on. If you've been in this game for a while, it's the usual suspects. We do the name fields, the address fields, date of birth, to do our matching. And we are using IBM's standard edition for our real-time matching. We've augmented their matching logic with some of our own proprietary logic. Next slide, please. Okay, next slide. Okay, as I mentioned, we have multiple MPI instances, and this is necessitated by all the various, the large volume of records we have to load every day. So we have it split up into real-time pharmacy benefit managers, the pharmacies, the provider organizations, and of course we we have to ensure that all the data we have in is meets strict quality standards. So yeah, so the as I mentioned, you know, we're loading the demographics. We also store in a segregated area information about the prescriptions, the pharmacy visits, the prescriber visits, but those are segregated from our MPIs for security reasons. So next slide. Okay, here's where I want to get into the our kind of our matching strategy. So our matching is real, you know, our matching model is real time, and we have, as I mentioned, 21 milliseconds response time, and we have this huge volume of records. So to augment these MPIs, what we've developed is a referential database, and this is where we consolidate all the records from the various sources to build up to build up a single record for every one of our patients. You know, one of the unique things is all the varied sources we have. PBMs have one source sets data. The pharmacies tend to have another different attribute. So within the referential database, we've is where we combine the records to build a single record for every person. And then we augment our real-time matching with the information we've put together in our referential database. And that helps improve both the quality, it helps improve the quality of our matching. The one thing I should mention about our referential matching, it's completely proprietary logic. And it uses some really innovative techniques, which I'll talk about in a second. Right now, we're not using any unique identifiers. We're still in the evaluation phase for that. And I'll have some more to say about that in a few minutes. Okay. We also have some unique ways of measuring algorithm performance. You know, there's always this issue of how do you evaluate or how do you determine, you know, your false positive risk. And we've come up with some ways to evaluate the risk using demographics, and that has to do with name frequencies, clustering of ethnic groups. We built up a lot of demographic data, and we use that to evaluate our false positive risk and help tune our algorithm. So the next slide, please. Okay. So let's talk a little bit about some of our lessons learned. The first thing is, and we make a strong recommendation to make all of the standards more flexible and kind of have a rapid turnaround on changes. And the kind of the biggest example is the X12-270 eligibility request. The X12-270 eligibility request does not allow phone number, does not allow multiple addresses or multiple names, and it makes it really makes it hard to, you know, it limits the matching behavior. So, and the turnaround time for changes to 270 is years. So it's a big issue. It's a big issue. Something else we've learned is that any good matching solution is going to require a hybrid approach. So, you know, a probabilistic matching has its strength and has its weakness. You know, the strength is it's able to deal with the nuances within names, nicknames, phonetic names, at a distance. It's able to do with the nuances within an attribute. What it doesn't do very well is it doesn't recognize patterns, you know, with it among the attributes. And the classic example is the twin pattern, where they look almost the same, but there's the classic twin pattern where you have a different first name, sometimes a very similar first name, everything else lines up. Probabilistic algorithms it's fairly easy to fool a probabilistic algorithm with twins. So the trick here is to identify the strength and the weakness of each approach and to come up with a hybrid solution that accents the strengths and minimizes the weakness. And beyond that, we also want to add in a reference database. So a reference database brings additional information into the solution. Okay, so very often, the problem is not the actual matching algorithm, the comparison algorithm. It's you don't have enough information to make the decision. So if you can build a more complete definition of all of your patients, you can use that in your real-time matching logic, and that will improve it significantly. Just a couple of examples, and I mentioned twins earlier. You know, one of the strategies we're implementing is identifying twins ahead of time in our reference database. If you identify twins ahead of time in your reference database, you can use that to minimize your false positives from the twins. The other thing you can use on the other side of the coin is if you can establish family relationships, you can use that to track people as they move from location to location. If you know that a parent has moved from location X to location Y, and you have this family relationship, then you can associate both addresses with the children. And that helps tremendously. We've looked at all of those near matches. Those are the things that are just below our match threshold. And these are what we consider our opportunities. And more than 50% of our opportunities are their matches on name, date of birth, different addresses. And statistically, we can look at those and say the majority of those are matches, but we don't know which ones. So the big challenge is tracking people when they move, and we found that the family relationships help us do that. So next slide. Okay, I think I've covered most of these points, but yeah, we found that referential matching will dramatically improve patient matching. And just a few examples I've given you, it can decrease false positives and increase false negatives. And we've been building up our referential database using only internal data, and we've had great success with that. We've taken, beyond using families to identify matches within our referential database, we also use some innovative techniques for ID matching. One of the things, if you start looking at these healthcare IDs, you'll find one ID embedded in another one. So if you can identify those types of matches, that helps tremendously. Also some very innovative techniques about names, very sophisticated techniques for names. So well, about biometric data, we're looking and constantly evaluating biometric data. From what we've seen, it's not there yet. I mean, what is needed for biometric data is you're going to need some exchange standards. You're also going to need some comparison, some good comparison algorithms. So we don't consider biometric data right now beneficial, but we're following it very closely. So next slide, please. Okay. I want to talk a minute about universal patient identifiers, and not just universal identifiers, but identifiers of all types. There's a lot of challenges I think that have to be solved before we start using a universal identifiers. First of all, when you're using a universal identifier, or really anybody's identifier, you're putting a lot of trust in the people who are producing those identifiers. So if there are issues with their identifiers, if they've created false positives within their database or false negatives, you're essentially importing those false positives and false negatives into your matching. So there has to be a process of, there has to be some transparency for anybody who wants to propose a universal identifier in how they produce that identifier, and there has to be some way to evaluate the quality of that identifier. So that's a big risk. That's a big risk. I think that, you know, a lot of people are looking at universal identifiers as a magic bullet. It's not. It's letting somebody else do your matching for you, and you better be sure that they're doing it correctly. The other thing you have to think about a little bit is even the best of the universal identifier implementations are going to have false positives and false negatives. Hopefully a very, very small %, but they're going to be there. Once a universal identifier is out there, it's out in the field, and all these various groups are using it to enhance their matching, what do you do when you discover an error? How does that information get published to everybody who's using that identifier, and how do they fix the issues that has been created? So I think those problems really have to be looked at before we even consider the universal identifier. And again, all of this applies not just to universal identifier, but to more local identifiers. You've got to be very careful when you use them. And regardless of, you know, if you decide to adopt it, you should never rely solely on the identifier. There should always be, you should always be doing your own matching to verify those matches. So, okay, I guess I've used up my time, so thanks for listening to me.
Do you want to slip to the last slide where you have
Okay,
the contact information? Or?
Yeah, let's go to the next slide. Okay, oh, yes, so, yeah, so I think I've covered most of these, but, you know, I think that, you know, the standards is a big issue, all the exchange standards that we have to conform to. I've covered that. The other thing that would improve matching greatly, and that's building referential database, is if we could get more access to some of the records out there. I mean, the big one would be birth records. If we could get access to the birth records, that would help us tremendously build up a complete picture of our users and improve matching. So, and again, I think this goes back to the issue of universal IDs and identifying universal IDs. We need some sort of platform where you can evaluate and discuss the accuracy of somebody's process.
Thank you so much. I really appreciate it. I'm sorry we have to move on. Next, I would like to introduce Dave Walsh, who is the chair or co-chair of the NIC Project Unify, which he will cover. Dave. I know Dave is on. Do you mind turning on your camera?
Yeah, so can you hear me, Carmen?
Yes.
Okay, thank you.
I apologize, thank you.
So what I wanted to do is just set a little perspective on what we're doing in the NIC and in the TAC and so forth, because many of the presenters that preceded me really are feeding us with information that we need to consider. So we're not focused so much on building similar technologies to what they have. Rather, we're looking at how do we implement that to address our specific problems. So let me give you just a tad of background. Myself, I've been involved in Medicaid for a couple of decades now. Chaired a group called the MITA TAC, or Technical Architecture Committee, and really focused on the technologies that would help the Medicaid systems as they go forward. More recently, I have been involved with a group called the NIC, or National Interoperability Collaborative, and they're an effort out of Stewards of Change to really look at how we bring together health and human services. So when we take a look at an individual, certainly clinical healthcare information is a component of it, it's important, but there's also quite a few factors that affect that individual outside of just pure healthcare. In other words, if they don't have a place to live, they have food insecurity, no transportation, then addressing their healthcare needs is a much more difficult problem. So what we're trying to do is look at how we start to bring in some of the human services data, the social determinants of health and so forth. And the way that we've been at this for about a year now, the way that we believe is the best way to start to address this is by taking a model out of healthcare. So how is healthcare doing things? Initiatives such as FHIR, which is really important for the exchange of the data, and SMART on FHIR, how do you authenticate and authorize the use of that data and so forth. The goal being, can we actually mimic or borrow from all of the efforts that are being put into healthcare to eliminate timeframes and eliminate the risks associated with also bringing in the social determinants of health as we move forward. So the NIC is really about demonstrating the art of the possible. So we focus a lot of our effort on this thing called a proof of concept, where we're actually doing some of these initiatives, implementing them so that we see what are the issues. And it gives us an ability to be bold in the beginning, to possibly fail at what we're doing and restarting. So it gives us some latitude to be innovative as we move forward. Another big factor in doing this is the engagement of our membership to be able to educate them. As we started in healthcare, things such as FHIR and SMART and OAuth 2 and so forth weren't well known, and it's becoming more known in the healthcare industry, but in the rest of human services, it's not so well known. So it's an opportunity for us to engage the community, see what their needs are, and educate them on the possible approaches for addressing what their needs are. So one of our projects has been cross-domain person matching or identity matching. And we'll see in a moment in one of the slides where that's a bit more difficult once you have the diversity of domains that we're working with. So it's not standard FHIR transactions and so forth. And there are limited things that we can do initially. We're not going to be rewriting all the systems that exist. We're going to have to evolve those. So I look at the presenters that preceded me and really look at them as our educators. You know, I've had a long relationship with Alan Byers, who just went before SureScripts, and he certainly helped educate a lot and has participated in some of these efforts in the past. Pradeep, who discussed earlier, is working with the NIC on these initiatives as we move forward. So the purpose is to gather information from the presenters previous to me, bring them out to our community in a context that makes sense to them. This is what we need to do, and this is how we're doing it as we move forward. We also have a large focus on open source, or at least open APIs as we move forward. We're really interested in getting participation from the industry and have people be able to build upon what we've done. So it's primarily about education and how we move forward to incorporate the social determinants of health. Next slide, please. So the goal right now with person matching is that we're going to not try and invent the algorithms and the technologies that we've been hearing about this morning, but rather define APIs that bring that functionality out to the human services space, the social determinants of health, and so forth, so that it makes sense to them. We're not really focused on how do we compete with SureScripts, as an example. We're looking at finding people who have really useful algorithms and putting them into the APIs that we're making available so that they can be put to use. And we've done that with a couple of people so far. Sensing is one that has some person matching API algorithms that we're looking at incorporating in the proof of concept. MyHIN, who has been a great partner of the Michigan Health Information Network, to actually bring some of those resources to the proof of concept. Next slide, please. So if you look at the problem that we're solving, that we're focused on right now, it really is primarily focused on the individual or the family. So healthcare is a part of it, and you see healthcare at the 1 o'clock, 2 o'clock position, where that's a piece of what we're doing, but there are also other components such as behavioral health, human services, housing, education, judicial, transportation, a vast number of other areas that affect that individual. So although healthcare is important, it's just a piece of it as we move forward. Next slide, please. So the approach that we're looking at right now is one of a person matching RESTful API, because we're trying to be language agnostic as we move forward on this, and then a series of pluggable algorithms in the center there, which may focus on Sensing's APIs or something out of the Michigan Health Information Network. Many of the discussions that we had earlier today are going to be algorithms that we're looking at. How do we incorporate that into the initiative that we're trying to move forward? And then on the very bottom, you see the domains that we're going to be trying to access information in and actually do person matching across those. So is Dave Walsh in health the same guy as David Walsh in human services? And that's a significant challenge to do the cross-domain matching. But again, it gets to, are we addressing the whole person, both the healthcare and the human services components? Next slide, please. If you look at the group, and we'd love to have anybody else participate, we can see folks from MyHIN, from consulting groups like HLN, Book Zerman, the Might Attack, and so forth. So we're all trying to bring our unique set of credentials, knowledge, and interests into this proof of concept so we can actually see, is this really working? Are there other approaches? Are there other technologies that could be incorporated? And certainly, it's a mixture of person matching authentication, authorization, components like that that have been discussed today, but are even broader than just the smart on fire APIs, for example. So we're looking for people to bring their expertise into this group, and I'm sure we're going to be reaching out to many of you to try and incorporate advancements that you have made. Next slide, please. The core functions that we are addressing are things such as person matching and identification, basic security platforms. A good deal of what we're looking into now is how is FHIR doing, and how can the successes of FHIR be replicated into the human services space. So next slide, please. So if you'd like to learn more about what we're doing, love to have you. You can either contact me at this email address, dwalsh@mitattack.org, or Daniel Stein, who is really the brain trust behind Stewards of Change. So we'd love to have you all participate. We'd love to know more about what individuals' approaches should be considered as we move forward. So that's it for me, Carmen.
Great. Thank you so much, Dave.
Sure.
So we may have lost a break, but we caught up in the agenda, and it is 2:20. We're going to now move into operations and governance. And first, I would like to introduce Dr. John R. Talbert, there he is, who is Acting Chair of Information Quality at UA Little Rock and Lead Consultant for Data Quality and Data Governance at Noetic Partners. Dr. Talbert.
Thank you very much. Appreciate the opportunity to speak. Unfortunately, I have a lot of animation, so whoever's handling the clicks will have to help me a lot. So click through to the next screen and just go down to the bottom of the left-hand column. Just, yeah, all the current stuff. Yes, thank you. So as Carmen said, I do teaching and also do consulting. One of the things I want to talk about a lot in my presentation, as much as I can talk about in 15 minutes, is standards. We've talked a lot about standards, but you may not be aware that the International Organization for Standardization is really weighing in on data quality standards. They're building a parallel set of standards to the old ISO 9000, which were process standards, process quality, and now developing data quality standards. And I think several of those could really apply to the patient matching and identity problem. Okay, click through to the next column. So I've had some industry experience. I worked in the research and development for Axiom for several years and helped them develop their Abilitech identity resolution product, and also had some experience building scalable entity resolution systems at Black Oak Analytics using HDFS platforms. Okay, next. So just click through this. The things that I want to talk about today are, what's quality, data quality, and how might it apply to patient and identity matching, patient and data governance. Not so much about data governance. I want to get to the ISO 8061 standard for data quality management. And also another thing that we mentioned earlier, I know Norm Adams talked about this idea of a birth certificate. There's actually an ISO standard for a global identifier that's based on what they call authoritative legal identifiers. And I'll talk a little bit about that. Okay, next. And so, yeah, just click, there's about 6 of those there. So we see a lot of things about quality, but what really does it mean? So next slide. So again, going back to ISO, quality is meeting requirements. Next. So, it's the degree to which a set of inherent characteristics fulfills requirements. So quality only makes sense in the context of requirements, and data quality is the degree to which data meets data requirements that we sometimes call data specifications or data standards. Okay, next. So let's talk about this in the context of a patient identity system. Okay, a couple of clicks there. So we may be getting patient information in batch updates or transactional updates, but we know that we can't match everything to everything. And so we have to block it some way or build a candidate list. And then we go into a matching engine where we use, as you talked about, these could be deterministic type of algorithms or probabilistic or hybrid. And now a lot of people using machine learning. And almost all of these systems will also push out some clerical reviews, some remediation where the system is at least tuned to say that, these are very close matches and that I'm unsure about. And then, of course, that requires keeping all that identity knowledge in some kind of an identity base. And then once you cluster the records for the same patient, then there's a data fusion or a data integration process where you're going to build the product, whether that's a clinical chart or some regulatory report. So there's a lot of ways then that the errors can get into this. So first of all, there can be data errors that the data itself, as we're very familiar with, miskeys and transposed characters, missing data. And then there's possible errors that come from the blocking where your candidate list is incomplete, so you don't ever get the chance to match your record to the proper candidate. And then obviously none of the matching engines are perfect. They all will create some level of false positive, false negative errors. And then actually, even when you try to remediate, you can have remediation errors that make a wrong decision when they look at the exceptions report. And then, of course, there can be errors in the data integration. And then when you do quality control on the products, then, so all of these need to be addressed through a data quality management program. And that program is supported by data governance. And so this is where data governance comes in to provide data quality standards. Your matching is basically a master data management, patient master index. And then your data asset standards in terms of your products and data integration. So this is then how I see data quality management and data governance relating to this whole process of patient identity and matching. And I've had the opportunity to review a lot of these systems, and I find that often this is lacking, especially on the data quality management side. And many people are still struggling with the implementation of data governance, although I think Dave Lotion is going to set us straight here in a few minutes. So next slide. So in my opinion, the keys to successful data quality management, first of all, you have to manage information as a product. So look at what your end product is and work backwards. Next, what I see a lot is instead of working on the demand side of data quality management, starting with a product, a lot of people want to kind of use supply side data quality management where they want to start by just cleaning the sources without looking toward how those impact the final product. And they use a method I like to call what could go wrong, where they believe if you take your input data and you scrub it as clean as possible, and your software, you debug it as much as you can, that when you run that data into that debug software, then everything has to be okay. But we really need to think about all the way back to Duran and Deming. And you really start with quality control, which is the inspection of your products as they're coming out. Next. So one of the things then I wanted to talk a little bit about is, and again, I've been working in the working group that at ISO that's helping develop these data quality standards. One in particular I'd like to point out, and that's the ISO 8061 standard, part 61, which is a data quality management reference model. Next. It comprises three processes: an implementation process of the actual implementation of data quality management, data-related support services, and then, of course, provisioning resources, especially in terms of personnel and training. Next. So this is, I took this out of the standard, and this gives you an idea. Those are the three boxes there: the implementation, the data-related support, and the resource provisioning. And I won't go through these in detail, but as you see, as we click through, it's really based on a very solid foundation all the way back to Deming in the Plan, Do, Check Act, or the Plan, Do, Study Act method of continual improvement. Okay, next. So I would recommend, in the short amount of time we have, I just wanted to put out some resources that you might want to try to take advantage of. So first of all, the standard itself that you can get from ANSI, which is the American National Standards Institute, is the United States representative into ISO. And it's not very expensive. And here's the great thing about it. It's a sort of a consultant's dream. It gives a complete set of 51 data quality activities and 82 data quality outcomes that you should be achieving in your data quality management. So that really gives you the what of data quality management. And then a few books, and again, I apologize to anybody that I'm not mentioning, but I'm very familiar with these because these are the books that we use in our program here in the Information Quality Graduate Program. And so one especially is Measuring Data Quality for Ongoing Improvement by Laura Sebastian Coleman. And that provides the how that goes with the what. She really describes in detail a data quality assessment framework, that DQAP. And that's been used a lot. As a matter of fact, our neighbor here in the state, Walmart, is using DQAF in their systems. Another foundational book that's really good is Journey to Data Quality out of MIT Press. Another one that's very, very practical and hands-on is Executing Data Quality Projects, Danette McGilvery. And I believe that's been out a while, but she's coming out with a new edition soon. And then for value proposition of why you want to do data quality management, Tom Redmond's Data Driven book is really good resource there. Okay, next. So I did want to mention, I mentioned earlier, some of you have talked about these universal identifiers, and and of course I never used to believe in those, but actually they've come up with a really good idea in the ISO 8000. There's two standards. One is the 800115 that defines a quality identifier. And what that means is that it can be resolved to the owner of the identifier and provide you with any restrictions on the use of it. And then recently they've extended that, and they have now a new standard, the ISO 800116, and it's the application of Part 115 to what they call an authoritative legal identifier. And so it gives you a template for building an identifier for persons, and that persons could be a natural person, human, or a juridical person. And we've been working a lot with 116 for juridical persons, which are basically just companies. And again, the idea is that it's resolvable because it's based on 115. It's resolvable to the authoritative registration. And so for natural persons, as Norm mentioned, it could be a birth certificate. And for businesses, all the businesses are registered with some state or some government agency that makes it a public record. Next. So I didn't talk a lot about data governance, although it is very critical. Without data governance, someone mentioned very early on, one of the biggest problems that we have in all of this, in the data quality and the matching, is the lack of consistency. And that's what data governance brings. It brings a uniform way of performing your data management activities. They often say that data management is what you do with the data, and data governance are the rules for making decisions about what you do. So it's very key to have that. And as far as ISO standards, those are in development for data governance. And most people now, though, are falling back to the DMBOK, the Data Management Association Book of Knowledge. And then there's some other good. Rob Sainer has got a great approach to data governance he calls non-invasive. And of course, there are many others. John Ladley and David Plotkin really emphasizing the role of data stewards in the organization. So that's really about all I think I can say in 15 minutes. So, oh, there's the data governance tool, Sunil Soares. There's many really good books out there on data governance. And I always say it's really easy to talk about data governance, but it's really hard to do it. And so if you're engaged in data governance and struggling, it's very understandable. Often it takes organizations 2 or 3 tries to be successful in implementing a good data governance program. So don't give up. Okay. And I think that's really all I had to say. If you had other questions or things you want to talk about, especially about the standards, feel free to contact me. Thank you, Carmen.
Thank you so much, Dr. Talbert. We are going to move on to our next speaker, who is Dr. Daniel Pullen. He's Senior Principal at Noetic Partners, there he is, and affiliate faculty member at the University of Arkansas at Little Rock. Dr. Pullen. I think you're still on mute. One more mute.
There we go. Now I think you can hear me. Thank you.
Okay.
All right, everybody, thank you for taking the time to listen in to what I have to say. Today, I'm going to talk about really focus on a couple of components of matching in general, not just for patient, but I think they're both critically important for patient matching in particular. But before we get to that, I'm going to talk about kind of a lead up to it to understand why they're important. As Carmen said, I'm a senior principal at Noetic Partners doing consulting. I am affiliate faculty member at the University of Arkansas at Little Rock and know Dr. Talbert very well. And in a previous position before working for Noetic Partners, I was a lead data scientist for a company that actually had a matching engine they developed and sold. So I've done a lot of entity resolution and including on patients, but also outside of medical data as well. Can you go ahead and go to the next slide? Since we're very limited on time, I'm going to make some assumptions of knowledge that I unfortunately have to make with the allotted time. I'm obviously going to be talking about entity resolution is really the academic term that's used to refer to this, but it has many other names. So identity resolution, deduplication, matching, record linkage, identity management, and in the healthcare space, oftentimes you'll hear people refer to it kind of generally as MPI or Master Patient Index. And I'm assuming that you have some concept of what that is. I'm assuming also that you have some concept of matching outcomes and a little bit of knowledge about EHR systems. Next slide, please. So first, I want to talk about what I kind of consider to be the ideal patient matching solution. And this is a very simplified view, but it has some key characteristics that I think are really important. And we'll talk about them more in depth as we go. One of the things that I think is really important is that has to be able to accommodate multiple types of data. So you need to have effective matching on not only patient encounter data, which is obviously the critical source of data in hospitals, for example, but also health information exchanges, and even the data that insurers and payers and Medicaid, Medicare that they want access to. You really want to get down to the encounters that the patients experience when they go to health providers. But there's also other data too. It could be legacy EHR data, for example, which is very typical. in today's landscape. External encounter data from other data sources, such as other providers, or through a health information exchange, payer data as well, and more. And so that's really important. Obviously, I think already some people have talked about that today, that bringing data from different sources is really critical, and it's not always easy, but I think it's a key characteristic. And then also, if we think about the actual matching component itself, the matching needs to be transparent, and I'll talk about why that's important later. It shouldn't be opaque or a black box solution. And there's some reasons why, from an organizational perspective, is if you, like, for example, if you were a hospital or a healthcare provider, that's a very important characteristic to have that transparency. Obviously, we need to have acceptable error rates. We want to make sure that we can identify the patients accurately over time. And two, I really want to emphasize there needs to be some type of analytics metadata. And this encompasses actually a lot of different types of data. I'm kind of throwing it into one bucket, but it needs to really be able to provide insight to the managers of the solution and the owners of the solution, and also minimize the amount of external input that's required in the system. And then lastly, I want to talk about traceability. So data should be traceable from the minute that it hits the system to where it resides permanently. So if I have a patient encounter data or other data, I should be able to follow that all the way from where I manage the patient identities back to the input into the system. Next slide, please. So I really boil this down to 4 key characteristics. So I call it traceable, transparent, effective, and efficient. And these are not necessarily everything you need to have a good matching solution, but if you don't have these 4, it doesn't matter if you have other characteristics, in my experience. Next slide, please. So talk a little bit more about traceability. So I mentioned that, basically this traceability it's about lineage of the data, right? So and there's a couple reasons why it's important, but from when the data comes into the system at ingestion, I want to know everything that's happened to that data all the way until it's stored in its permanent location and managed longitudinally. It should, ideally the data should persist, and that I should actually be able to retrieve the original input record. However, there are some use cases where that's difficult. For example, if you look at like the HL7 messaging, for example, and you look at the volume of records that come from one provider, like into health information exchange, there can be, I've actually seen firsthand in the small state of Arkansas, for example, a patient that had, well over 1 million instances of their PII through HL7 messaging. So maybe we don't want to keep all of that data for technical reasons. However, if we don't keep every single copy of it, we should have a way to easily reconstruct it or retrieve it on demand. Next slide. And then transparent. So I really want to emphasize that the actual comparison engine is really what I'm getting at, the thing that actually does the matching. It should be transparent, it should be auditable, and ideally it should be configurable. Maybe not configurable by a health provider, but potentially by a service or a company that they employ to configure it. And I want to emphasize too that good results are not enough. So you can have good matching, but if you don't have insight into how the matching is happening, you can't really control that process. And so should be just having good results that are opaque, there's a fair amount of risk for the organization. It should provide metadata for analytics and support processes, and those could be quality assurance. I may want to estimate the accuracy of the matching. I may want to understand the error rates so that I can assess organizational risk and make sure it's aligned with the organization's risk tolerance. And ultimately, for health providers, we want to make sure that it's providing good patient outcomes. And this is an area that I've heard a lot of discussion around. I haven't seen anything comprehensive to date, but how the management of patient identities can directly affect patient outcomes. And importantly, it empowers the organization to participate in the management of their matching and the oversight. So rather than me as a health provider, I shouldn't trust 100% in a company that I pay for matching. For example, if I'm paying for an EHR system like Epic or Cerner or whoever, I should be able to have a seat at the table. I should be able to participate and have input and be involved in discussions around how that's managed. Next slide. And the matching should be effective. And this is often, I think, the point that is focused on too much. And bear with me there. I'm not saying that you shouldn't have accurate matching across a variety of data sources, but if you look in the research space, a lot of effort has been expended on getting better results, making sure that the matching that you create is close to 100% perfect, which is not possible. You know, it's not possible to have no errors in a matching solution. However, I think it is important, but we shouldn't forget these other three characteristics. And so effective, again, just to reiterate real quickly, it should support matching across a variety of sources and have an acceptable error rate. It won't be no errors or a zero error rate, but an acceptable level for the risk for the organization. Next slide, please. And lastly, efficient. So in particular, in the healthcare space, a clerical review is extremely common, and I'll talk about it a little bit more here in a minute. It has many different names. Dr. Talbert just called it remediation. Sometimes it's called adjudication, etc. And one mistake that organizations make is they implement this review process, but they don't have the resources to support it. And so really, when I say efficient, it's really about being appropriately efficient for the organization at hand. So more than anything, a specific organization should be able to appropriately manage cost and their staffing against their operational risk. Next slide. So let's talk about when this doesn't work correctly. What are the negative impacts? So let's talk about when you have incomplete or no traceability. Next slide, please. So when you have incomplete traceability, it's a major obstacle to quality assurance analysis. So in some cases, it's difficult or it's impossible. If you can't completely reconstruct all of the input data into the system, or at least have a way to reproduce the counts for it or something, that there is, like I talked about before, I think it's okay to reconstruct things in some cases when the data volumes or the group sizes require it from a technical perspective. But I should be able to recreate them for calculating my error rates, for example, if I want to look at false positive and false negatives or precision and recall. It can be an obstacle to comparing different systems. So for example, if I can't retrieve the data from the system at a later date, it may make it more difficult for me to compare to a new system that I want to potentially change over to. And one of the reasons why this happens in practice a lot is really what's often called in industry, and especially like in marketing, the golden record. Or I think of it more as consolidated PII or consolidated PHI. And basically, if you look at the picture on the right, I would have multiple encounters with a patient. However, I merge them into a single identity, and I might only keep one address or one name or one SSN, even though historically I've had many different variations of data for this particular patient. And this is, I would say, probably one of the most common oversights I've seen in practice, and not just in healthcare and matching solutions in general, is that you don't have this complete traceability to do robust quality assurance processes. Next slide, please. All right, now I want to talk a little bit about clerical review, and this is just a very simple picture. So clerical review is basically this idea that in addition to your matching or resolution engine, you have these signals or basically a review queue that's output by the system that a human reviewer validates and then makes some type of decision or judgment, and then those are returned back to the system. So basically they would either decide, yes, these are the same person or patient, in fact, so go ahead and put them into the same identity, or they're not, so keep them separate. Excuse me, next slide. And like I said, it has many names. So manual matching, manual review, adjudication. In the Boolean world, sometimes these are called soft rules rather than hard rules. And it's basically the human review of either matches that have already occurred or potential matches. So sometimes clerical review can occur as a post-process, as a component of a quality assurance, where you're looking at potentially risky matches. And in other cases, if you look at like how it functions in Filigy-Sunter, for example, you're looking at this as a band of potential matches that you're validating before the solution actually matches them. And what this does is it allows you to offset the push-pull of precision and recall. And excuse me, there's a mistake on my slide. And so if you look at this graph, if you imagine, and this is deliberately a very simple perspective of how this works, if you imagine a graph of precision over different levels of similarity and a graph of recall over different levels of similarity, there is some point where they are intersecting, and the functional result, if you're to consider F measure, for example, is the best overall result that you could produce. Now, one of the downsides of clerical review is it's not free. You have to expend time and resources, and it can be very expensive if not managed well. Next slide, please. So this is a couple perspectives of how you might manage clerical review. And again, these are very simple perspectives to try to get the point across. So I could optimize for precision, where basically I'm allowing myself to get some matches that are kind of advantageous to the precision curve rather than the recall curve. Or I may look at a review band that is optimizing for recall, where it would give me more recall by expending those resources. Or I may look at optimizing both, where the band is essentially on both sides. And keeping in mind that the larger that band is, the more expensive it is. And this is very much like how it works in Felige-Sunter, for example. Okay, next slide, please. And so when you have ineffective use of clerical review, it actually negatively impacts two of those four key characteristics I talked about. And this is a very common mistake that I've seen firsthand. And so effective and efficient are the two characteristics that are damaged. That your system no longer has these characteristics when you improperly use clerical review or use it ineffectively. Next slide, please. So what that means is, it happens for a number of reasons. You may have staff you don't have enough staff, for example. You don't have enough people to do the reviews that you've committed to. Your staff is not properly trained, so they can't review quickly enough, or the decisions they make are not accurate. Dr. Talbert mentioned that even manual review has an error rate. We as human beings have an error rate just like algorithms do. And the reason why it's really risky, in my opinion, is if you look at this picture on the slide, you imagine that I've set my target matching over here with this review band, but my actual matching results are actually shifted to the left of that. And what that means is that the actual results are misaligned with the expected risk profile, whether that's organizational risk from a legal perspective or compliance perspective, or if it's a risk with respect to patient outcomes. And just give one quick anecdote. I remember responding to an RFP at one point in my career for an organization that said they only had 2 hours a week to expend on clerical review, but they wanted that to be a part of their solution. And relative to the total volume of data they had, it's inconsequential. It would have no overall impact on the results of the process. Next slide, please. All right, with that, I know it was pretty quick. I just wanted to briefly touch on this. Lack of traceability and improper clerical review are both actually extremely common in practice in industry. And if you have any questions, like to discuss this further, I've put a couple of email addresses. You can reach me through my Noetic email or through my UALR email.
Thank you, Dr. Cullen.
Thank you very much.
I really appreciate it. Sure. Next, I would like to introduce David Lotion. David is Information Consultant at Knowledge Integrity, Inc., and he's Program Director at the University of Maryland. He'll be discussing data governance practices to improve the potential for UPI success. Hi, David.
Hi, thanks so much, and I appreciate the opportunity to come chat today. Can we move to the next slide? Just to give a little bit of my own background, I've been doing technology since 1987. I've been working on identity resolution and applied record linkage since 1995. In 1999, I formed Knowledge Integrity to focus on data quality and data governance consulting. And recently I joined the faculty at the College of Information Studies at the University of Maryland as a program director for the Master of Information Management program. Our company's done a number of projects on data quality, data governance, but I want to select out two in particular that give me two perspectives. In 2006, Knowledge Integrity was contracted by the Australian National E-Health Transition Authority, or NEDA, to deliver a data quality strategy and data quality framework that supported the creation of a repository for a national healthcare identifier for provider and individual identifiers. And then since 2013, we've been under subcontract to the Centers for Medicare and Medicaid Services as part of the forward engineering team, providing guidance for healthcare provider master data management and overall data strategy. And it's gives us a little bit of a perspective. And certainly, we understand the core people and socio-technical issues that are associated with a unified healthcare identifier or a unified patient identifier. And in that project, we highlighted some governance concerns that need to be surfaced and addressed. Our work with CMS gives us some perspective about technologies that support record linkage and matching and identity resolution. And it kind of points to the fact that technology solutions are necessary, but not sufficient to solve some of these problems. Can we move to the next slide, please? Thanks. So I clipped this out of some of the materials that were shared with us from NETA back in 2006, where they were talking about a unified healthcare identifier, what the primary purposes were, and these are just quotes that come from their documentation: accurate identification of individual patients across a variety of settings, ensuring that correct health information is associated with the correct individual, ensuring both electronic and non-electronic communications among providers and payers are accurately related to the right patient at the right time. So we have these terms: accuracy, correctness, unique identification, currency. These are all fundamental data quality requirements and expectations for operationalizing a uniform patient identifier. And yes, there are technologies that exist to support the deployment of a UPI. Identity resolution has been mentioned numerous times, record linkage, master data management, or EMPIs. And again, technology alone is necessary, but it's not sufficient to ensure the success of a UPI rollout. So let's move to the next slide, please. One of the things that we understood in the context of working with NETA and the Australian UHI was, or the National Healthcare Identifier, was that the requirements for data quality need to be filtered through the perspective of all the participants and integrate into those decisions the motivations of those participants and how they interact and what their incentives are. So facilitating the use of a UPI involves essentially a federated community of participants, and each of those participants has its own motivations to participate, its own incentives to comply with standards, to ensure high quality information, their own directives and rules that need to be observed, and their own investments in ensuring the overall success of the use of that identifier. So standards for interoperability across the different operational domains need to be defined and agreed to before you even start looking at technology issues. And I think that this gets reflected in terms of the emergence of externalities that could significantly impact the commitment of each of those individual participants in relation to the creation of value, you might say, that results from ensuring measurably high quality healthcare information. Can we move to the next slide? Thanks. So identity resolution, or rather approximate identity resolution, which is I think more of what we've been hearing about somewhat, is known as record linkage or matching or entity resolution. And I think that I've heard one aspect of the objective of identity resolution, which is determining with a high probability of accuracy that two records refer to the same real world entity. But we have a similar component, which is often not really referenced, which is being able to determine that two records don't refer to the same real world entity, or rather two records refer to two different real world entities. And I experience this all the time. In fact, I'm an example of what was referenced before. I have a relatively uncommon name, David Lotion, yet there's another David Lotion who exists, who it turns out is also an author and is also born the day after I was born, has a birthday that's the date after my birthday. So relatively close by. It's kind of a weird coincidence. So exact matching is straightforward. When you have all the identifying attributes populated and the values match, you can, with relatively high probability and expectation, you can say that two records are deemed to be a match. But approximate record linkage is much more complicated. There was references by Dr. Pullen just before about Feleghi and Sunter and research and algorithm development. associated with approximate record linkage dates back to the 1960s, if not earlier. And there have been incremental improvements in these technologies over time that improve precision or improve accuracy, but it would be naive to put full trust in automated approximate record linkage and identity resolution. And I think what the previous speaker pointed to is that there is a need for manual intervention and review in order to get the full benefit of being able to make use of these types of technologies. Let's move to the next slide, please. So in our experience, here's some of the issues that cropped up in being able to make use of a uniform identifier in a federated environment. And to a large extent, a lot of it had to do with the what I think John Talbert referred to earlier, which is consumer-based data quality requirements as opposed to supplier-based data quality requirements. So number one, standardizing objective data quality dimensions for measurement and being able to come up with a quantification mechanism that allows you to level set among all the participants to specify what a requirement would be. Number two would be identifying contextual use case data quality requirements and expectations across that federated community. And I see in the chat there's some comments about what's an acceptable error rate. And the answer that we would say is it really depends on who you are and what your use case is. And you know, if you're talking about making sure that the right patient is on the operating table, I would say that you don't have a lot of tolerance for errors in matching. Number three, formalizing methods to quantify and measure contextual quality according to those specific use cases. So yes, we can standardize objective data quality dimensions for measurement. However, what is the actual requirement and expectation is relative to what your context is. And this is where some of these externalities get introduced in that when I, as a participant on one side of that network that was on one of the prior slides, is collecting information and being able to add that to say an electronic health record. My motivations for collecting and all the data and ensuring that it's high quality are potentially much lower than the expectation of the consumer of that information somewhere down in a different environment. Number four is documenting externally imposed directives and regulations that govern cross-jurisdictional information exchange. You know, a good example that's a much more global example are the data privacy regulations, and being able to manage the assurance that protected identifying information is not being shared in the wrong context. However, in a lot of the context, and if you read through a lot of the HIPAA privacy rule, if you read through the GDPR, if you read through a bunch of these other privacy acts and laws, they provide a lot of detail about what are the permitted uses, and being able to manage those permitted uses is actually much more complex than enforcing against using the data altogether. And that imposes a lot of policy issues from an information perspective that need to be understood, articulated, and transformed into some kind of specification that can be operationalized, especially in a federated environment. Next would be architecting a technology stack that includes, but it's not limited to, identity resolution for not just for linkage, but also for continuous validation and monitoring and assurance of the quality of the data that's being collected. Next, socialization of the auditable conformance to data quality policies, data governance policies, and certification across those different participants among the federated environment. And finally, operationalizing interoperability across the different technology stacks, because not every organization that is going to be participating in this environment or in this network is going to be committing to the same set of tools, or the same set of databases, the same set of identity resolution techniques, et cetera. So these are a bunch of the challenges, and a lot of these challenges are addressed, if we go to the next slide, with some recommendations that scope around data governance. And so we'll start out with data governance, instituting a federated data governance framework, specifying an organizational structure and roles and responsibility and workflow for activities by the various participants. And I'll add another parenthetical comment. These are actual parts of the recommendations that we provided back to the Australian eHealth Transition Authority. And another parenthetical comment is a lot of these guidelines that we provided in greater detail were subsequently integrated into their legal framework for implementing their unified healthcare identifier. Data quality standards, defining and adopting those defined standards for information sharing, APIs, data interchange, and data quality dimensions for objective measurement, but instituting data quality policies and protocols for data quality assurance, for data quality control, for instituting auditing, for reporting, certification, as well as remediation procedures as part of that interaction and information interchange, along with agreed to service level agreements that would be adopted by the different participants, so that there was some level of comfort that if an issue was identified, that the data owner or the data originator would take the responsibility to review what the issue was and attempt to remediate that issue. The next recommendation was about technology and operations, to architect an integrated set of technologies that were vetted to support the implementation of the policies and protocols, as well as defining and recommending adopting standard operating procedures for making use of those technologies. Next would be performance management, establish performance goals and performance thresholds for validating conformance to the expectations across the federated community. What that means is that there needs to be an ability to not just collect those expectations and the requirements from among the different use cases in the federated network, but also to be able to communicate out all of those requirements and establish the levels of acceptability across that those communities, to ensure that everybody was meeting those defined thresholds. And finally, continuous improvement. If you employ a data quality maturity model, that can help you identify where there are gaps in any participant's ability to abide by those standards and conform to the performance goals and thresholds. It identifies opportunities for continuous improvement and therefore feeds into a continuous operational data quality and data governance. Can we go to the next slide? So I'll take John Talbert to task because he made a list of books, but left mine off his slide. So I'm going to recommend that he update his slide to include some of the books that I wrote on data quality. If you want to get more information or contact me with questions or comments, you can reach me at lotion@knowledgeintegrity.com. If you want to learn more about the Master of Information Management program at the University of Maryland, here's the link. And if you have questions about that, certainly don't hesitate to contact me about that as well. And thank you very much.
Thank you, David. That was excellent. We are just wrapping up the operations and governance block in the agenda. And now we're moving into the research block. And to kick us off on research is Dean Resnick, who is the Senior Data Scientist at the National Opinion Research Center. Dean. You've got one more mute button on.
Now you can hear me, right?
Yes.
Awesome. Right. So yeah, I've been listening to a lot of these talks, interesting topics. And I kind of regret that I see that there's been some interesting material that's been presented on record linkage. And I think I may have better allocated my time and my slides to talking about the record linkage work than some suggestions I made for a patient identifier. But let's see how much I can repurpose what is actually there. So let's go to the next slide, please. So what I want to talk about is the record linkage work that NORC is doing for the National Center for Health Statistics, where we are linking data from the National Hospital Care Survey to several files. First of all, the National Hospital Care Survey, a number of basically acute hospitals are in the frame and they're sampled, and the ones that agree to participate, which is only a small percentage, they actually send their patient records to NCHS. And so we get those records and we link them to several data sets, as you see, the National Death Index, so that we can determine which of the patients have subsequently died, and then the Medicare enrollment records. And moving forward, we're going to be working on other links to HUD data and to Medicaid data. And so the next bullet talks about probabilistic linkage. I just want to point out that the probabilistic linkage is actually done in conjunction with what I think other people have called exact linkage, or what we call deterministic linkage. And so essentially for deterministic linkages, we make use of social security numbers, and the probabilistic linkage is used on top of that. But they actually work pretty well in conjunction with each other. And as one of the previous speakers did point out, just because you have two social security numbers that agree with each other does not guarantee that you are working with the same person. So we actually develop a test deck, and we check the other identifiers to verify that there's enough similarity that we want to move a pair of records which agree on social security number into our test deck. But for the probabilistic linkages, the linkages are made using essentially names, date of birth, and addresses. I guess we also use sex. We're not using other characteristics too much. And in terms of how accurate we get, and I probably should spend a little bit of time talking about how we measure accuracy, we find, and this is just for the probabilistic links, that we're getting about 98% of the true matches. And we measure this primarily by running the truth deck through our process and seeing how many records are returned by the probabilistic process. And then we have a false discovery rate, or what percentage of the links that we come up with are actually not valid. And so our evaluations are being done on an automatic basis. We're not making use of clerical review. If you go back to Flagey-Sunter, they do recommend a clerical review. There's several issues with clerical review. I guess the biggest issue is it's expensive, depending on the region of your indeterminate zone is going to drive the cost. Another issue is that if you're doing your linkage well, then it will be the case that even for the indeterminate cases, it can be very hard to determine, are they truly the same people or are they not? So there's certain accuracy issues related to making those determinations. Now, we are making our determinations essentially for statistical purposes. So you can argue certainly that if someone is doing their linkages for the purpose of assembling someone's medical history, that your tolerance for error is going to be significantly less than what you would what you'd be willing to tolerate for statistical purposes. But getting into how we measure the error, and actually, our probabilistic process, we actually compute a probability that each pair is a valid match. So like any well-designed record linkage, the distribution is bimodal. There are many pairs which have very, very high probability of being true matches, and there are very many which have low probability. But there are in-between cases, and they go from the whole range. So, I mean, depending where you want to say a cutoff would be, you could go from, say, 70% of probability of being a match to 95%. And like I think there was a previous speaker, you know, where you draw that cutoff, it depends on your use case. And we actually are able to compute the error rates of making the cutoff at various different points. And then one other thing I will say is that we have also gone back to the Filegi-Sunter model and developed a probabilistic model, which does not use the truth deck, but uses the probability computation so to determine what the probability is that every record is a match. And one thing you can do with that probability, if you know what the probability that the records that you link are not matches, then you can directly estimate your error rates from that. And we have tested this, comparing it to the test deck, and we find that the results are comparable. So we think our probabilistic model is a viable alternative for computing errors. Now, getting back to the patient situation with a medical history, if my doctor is going to do surgery on me and they want to look up my medical history, I would almost want to just say, you know, let the doctor do his due diligence and verify that all the records that have been sent back for me are these really, you know, things that happen to you. I mean, if that's going to depend on how he does the surgery, then I think it's important enough to verify these things, because this is probabilistic record linkage. There's always going to be error on both sides. There's going to be errors with the links and errors with those records which you have not linked. And then I do want to say that the error rates that we gave do exclude records which have substantially incomplete identifying data. So essentially that would mean they were missing either a name or a date of birth. And then how we say, like, a date of birth, we're happy with the date of birth if it has a month and a day or a year and a month, two of the three elements, and similar rules for name. But essentially, when they fail to have a certain level of data, we do exclude them. And obviously, you know, in the real world, the people who you exclude can be marginalized populations. And so this could be it's actually a problem also from the statistical realm, because you could be biasing your results by focusing on maybe higher income people who are more easy to link than someone without. And the other thing is, because we do have social security numbers and also have for the Medicare match, we have the HIC number, we are able to substantially reduce the error rates even below what I consider to be pretty low levels. So I just want to say, you know, record linkage can be done effectively with fairly small error rates. You know, whether that's sufficient is kind of in the eyes of the beholder. Clearly, there are reasons that you want to be able to do even better. And so I'll turn to the next slide, if I can, and talking about developing a new patient ID. So what is the goal of the new patient ID? Very simply, rapid and reliable linkage. Again, the reliable is, you know, yes, there's still some error rate possibilities. You would want to be verifying the records both with the other identifying data and possibly with the patient themselves. And the two uses I was anticipating for a new patient identifier would be the delivery of healthcare data and the analysis of health data. So I know I've listened to some of the earlier speakers, and I'm probably, you know, not as versed in the data security issues which are related to having a patient ID. But from my perspective, when I was thinking about what it would be like to develop a new patient ID, I was thinking that that no data, first of all, that the patient ID would be held in a database similar to what holds your social security number, which is held by the Social Security Administration. And that database itself, it would not include any medical data. It would not be a medical data repository, and would have very limited data, maybe a name and a date of birth on it to be able to confirm the identity. So in terms of, you know, having an ID, does it invoke security risks? That may be the case. I was envisioning that just because I have an ID doesn't give me the right to see the medical records associated with that ID, unless I have some way of verifying my identity, or I'm some kind of trusted researcher who has to conform to all sorts of security standards. And then the question of why not use the SSN, and my thinking was that, I think one of the other speakers, at least one of the other speakers, I haven't been able to listen to all of them, suggested that the social security number, even though we know that it's out there on the dark web, and maybe not the so dark web, but still people don't like to have it floating around for anyone to see, because there's a lot of financial data associated with it. So that the advantage of having another ID would be that you wouldn't have to give the social security number. It would also enable identification of people with social security numbers. Clearly, not everyone living in the country either qualifies to have a social security number, or for some reason they didn't actually apply for a social security number. And so my suggestion was, you know, am I at the end of my time? Okay, I don't even have a contacts page, but if you're interested in the methods that we use, feel free to look me up at NORC, N-O-R-C, and just by my name, and I'm sure you'll be able to find me. Not that hard to track. Thank you for your time.
Thank you so much, Dean. Next on the agenda, there he is, Dr. Sean Granis, who is from the Regent Street Institute and the Indiana University School of Medicine. Dr. Granis. Can we move forward in the slides, Jennifer? It's not visible yet.
All right, there we go. There it is. Perfect. Excellent. Well, thank you, everybody. It's been a great day hearing a number of different topics and conversations. My trick to being able to adapt my presentation to the day's great content is just to have one slide. That way I can adapt as we go. So I'm in the research section, so I certainly want to make sure that I connect my comments to research, and I will indeed do that. But I do want to, I think Dr. Gettinger early on sort of framed why we are here today. I say it simply, we as the US lack any consistent, standardized, aligned approach to identity. Whether that approach is algorithms, whether that approach is identifiers, or a combination of both. By the way, I don't know if you can read my whiteboard that says two things can be true at the same time. It can be true that both identity and algorithm may be useful in solving this problem. The key is making sure that we have a consistent approach, that we have alignment on what it is that we are doing. Because we lack a consistent identity for the country, we have suboptimal identity, and suboptimal identity, of course, leads to inefficiency. It leads to poor outcomes. It's a patient safety issue. We are the last developed country in the world to develop a national strategy for identity. You notice that as I'm speaking, I'm not saying we're the last country in the world with a unique patient identifier. We may become a country in the world with a unique patient identifier as its primary strategy, but we may become a developed country in the world that uses a variety of approaches. But the key is, and why I think we're all here today, is to help move the country forward in that cause towards consistency. So as we start thinking about how to do this, I think there's a couple of thoughts about near term and long term. And I think we just need to be pragmatic about where we're going. Every one of the speakers today has been touching the elephant of identity management in different places. I would even argue perhaps we're tugging at that elephant, maybe wanting to pull it in different ways. And if we're going to move this elephant, I think we're going to have to start pushing together. And in order to push together, I think that we're going to have to come up with, we're going to have to agree on current state and then where we're going to go with this current state. Current state is we don't have a unique identifier. Current state is that we're using all sorts of different approaches, largely algorithmic. An algorithm sometimes even gives a little bit too much credit to some of what we're doing, but we have different methods, different rules, different business logics. Sometimes we assign an identity within healthcare systems, but underneath that are rules, algorithms, etc. That's what we're doing today. At the core of our identity for healthcare in the United States are algorithms. And so that's the current state that we have to deal with and accept. As we think about these new, very promising concepts around developing trust frameworks within which we can assign unique identities and then be able to exchange identifiers, that doesn't exist yet. And when we're talking about a $4 trillion industry in arguably one of the most complex socioeconomic, political countries in the world, we're not going to change current state overnight. So my call to this group would be the following. How do we continue to improve current state, which is not going away tomorrow, while planning for future state? I saw in the comments from Genevieve Morris the observation that there are some places that are sort of caught in a cycle of trying to optimize current state and not being able to think about future state. That's, I think, one of our greatest challenges, is figuring out how to bridge where we are with where we're going. If I don't let my cat out of my office, he's going to continue to make noise, so excuse me 1 second. And I'm back. Coronavirus mixing work and home. Great example. So, so we need to be able to think about how to transition from current state to future state. So for example, this is where I'll bring in some of the research that I've done, and others have done some brief introduction. So I've been working in patient matching, not the longest of anyone certainly on this call, but since 2001. and have done a fair amount of research, federally funded, internationally funded research in patient matching, identity management, several publications. But some of the research recently that we've done shows that, not surprisingly, standardizing data improves match accuracy. That's not rocket science. We've known it for a long time. We've done some work to show the degree to which that is true. In our studies, we find that not all data sets benefit from standardization. So in the current state world, in the current state mindset, what can we do to improve? If we know that standardization makes sense, one of the observations that we've made is, well, if not every source of data will benefit from every type of standardization to improve match rate, is there any way that we can figure out which data sets will and which data sets won't? So we published a paper a couple of years ago showing that standardization improves match rates. We're now working on data quality metrics, and I really appreciated Dr. Loshin's talk on data quality. We're working on data quality metrics that help us know and identify those data sets which are amenable to improvement, and developing metrics that can help us understand the degree to which those data sets are amenable to improvement. That would be useful and valuable rather than blindly devoting resources and expenses to making significant changes to data. What if we could target those candidate data sources that are best positioned to benefit? And why would there be different benefits from different data sources? Well, we've talked today at least a little bit, recognizing the fact that different types of data in healthcare produce different matching outcomes and have different challenges. So for example, the newborns, the twins, the familial linkages, all of those are challenging aspects of healthcare data matching. And to the degree to, in the current state, where we're using algorithms, to the degree to which we can identify guidance regarding what approaches can help us improve current state, I think would be useful. And that's, again, an area of research where my research lab is going. So I think we need to have some conversations about what other aspects of matching can be improved through standardization, through alignment, through consensus. Regarding the future of identity, 20 years ago, we did not have Facebook, and 20 years ago, we had very different perspectives on the concept of unique identification. I think the conversation is maturing and emerging, and our culture is becoming more comfortable with the idea of being uniquely identified. That doesn't say that I think a unique identifier is the absolute solution, but clearly culturally, we are becoming more familiar with things like a fingerprint sensor next to us at all times, or facial recognition next to us at all time. We are living in a different place than we were 20 years ago. And I do believe that the trajectory of the conversation, the trajectory of the research, the trajectory of the deployments and implementations we're seeing in identity management around the country and around the world suggest that other approaches beyond algorithmic identity management are going to become more important. And so understanding what that next state is going to look like and beginning to develop alignment on that state will be important. Fundamentally, I think it is hard for us sometimes to think about the as is and the to be. And it's a lot more exciting. It's a lot more interesting for me intellectually anyways to think a little bit about what the future is going to look like. But there's so much work yet to be done in optimizing and actually bringing and establishing consensus on the current as is state. So I will end with this. I know that I believe I have a couple more minutes, but I will just leave with the following. There are 50 different ways, and 50 is just a placeholder number. There are many different ways to solve this patient identity problem. In fact, the solution to identity that we'll be deploying in 5 years has probably been in existence for 20 years. It is the social, political, economic dimension of this problem that we need to solve. It is the alignment of trajectory. It is the getting everybody to put their shoulder on the elephant and push it forward rather than pulling it from side to side or forward and back that we need to accomplish to make, to be successful and improve identity in this country. Stated simply, patient matching is a social, political, economic problem disguised as a technical one. Thank you.
Thank you, Dr. Grenis. We now are actually on a break. We have a break until 3:45 Eastern, and then we'll come back with a few presentations on innovation. So enjoy your break. Stay tuned. Good afternoon. We're coming back from break. Our next few presentations will be focused on innovation, and it is my pleasure to introduce Dr. Naresh Sundararajan. Hi, Naresh. He is the Chief Technology Officer and Vice President of Technology and Operations at the Nebraska Health Information Initiative. The floor is yours.
All right. Thank you, Carmen. Can you guys hear me?
Perfect.
Yep. So could you please move on to the next slide, please? So today's talk, I'm just going to focus on 4 main ideas. So first of all, I'm going to touch a little bit about all what we've been talking throughout the day on why patient matching is complex and what are the barriers that we are facing on a day-to-day basis within health information exchange, which is very generic if you think about it. So the other thing, the next thing I would be following up with matching algorithms as such, and how much of a burden data practitioners actually are facing in picking the right algorithm and matching metrics. Then would come up with a sort of a bottom-up approach on how we could actually think about it or rethink about the existing ways how we actually can align the matching algorithms with the transactional data sources. And then finally, embracing the latest technology, which is specifically machine learning and AI to augment the decision-making process. Next slide, please. So thinking about the barriers as such. So if all the topics that we have discussed so far, if we have to put it under 2 broad categories, we are talking specifically about semantic and syntactic heterogeneity of the demographics data. So right from the data modeling, the different standards and the different ways by which we actually exchange the data. So we could actually consider that as a, if we just try to put it under one topic, we would just say it's semantic and syntactic heterogeneity of the demographics data. This is always a barrier to patient matching. And the second thing is lack of transparency of the algorithms. So, which is something again, we discussed in detail about, there needs to be more transparency, and it's evident that even in the chat sections, I've been looking at comments and everyone is also commenting that there is a need for ONC or a federal agency to involve in understanding the transparency of all these algorithms, so that even if it is an open source or a vendor mediated, we have to have some sort of a transparency over these different algorithms that exist out there for understanding patient matching. So this point 1 and 2 actually leads to the topic of why we are not able to compare the efficiency of matching algorithms. So if you think about that, due to different data sources and the heterogeneity of it versus lack of transparency, we cannot actually compare the efficiency of a matching algorithm when it is applied on a data source. And then what we have to understand is the big elephant, or in other words, kind of the elephant that Dr. Grenis was talking about a few minutes ago. I would just put a spin on that, which is data quality as such. I'll talk a bit more deep about that in the next coming slides. And finally, as we always know, the security and privacy issues that comes with the patient matching as such. Next slide, please. So why is this challenging? So matching algorithm as such, choosing the right one or the right vendor or getting a consensus out of this matching algorithm is always a burden to the practitioners. As a HIE, we face this on a daily basis. So we have a separate patient matching algorithm for PDMP. We would have a separate patient matching algorithm or another whole new matching metrics for our HIEs. But when we start combining these two different data sets, it's always a challenge for us. And it is evident that there has to be some sort of aggregation or some sort of common approach that has to happen at a national level. And this is due to lack of consensus-based approach in evaluating these different matching metrics or algorithms as such. And then comes all the different matching metrics, if you think about it. The matching quality metrics, such as F-score, F1 score, sensitivity, specificity, true positive rates, false positive rates, and everything. And then the matching complexity as such, the reduction ratio, and pair completeness, pairs quality and completeness. And then finally, we are actually thinking about how do we create a similarity score, which is defining the interoperability of the data between cross facilities matching. So if you think about this, it's very similar with respect to universal patient identifier as well. The whole idea of getting into the resolution of historical data, we would face very similar challenges that we are facing right now. And we have to think about a different approach. And next slide, please. So what my theory here is that the elephant here is the data quality, if you can think about the center of the slide, which we don't try to ignore often in this conversation. At least I've seen people talking a lot about it, but what can we do about it? Can we actually build infrastructure to understand the quality when the data is rising at the source? And how do we actually can evaluate the quality in a consensus-based framework before even we get to the matching algorithm? Like Dr. Granis said, and his team is working on this, there are ways by which we could actually increase the accuracy of matching or efficiency of matching algorithm if we consider the quality of the data before even we get to the matching aspect of it. Next slide, please. So the whole idea of this bottom-up approach is that we would start with evaluating the quality and complexity of matching algorithm in synthetic but near real-world data set. This is easier said than done. You can think about the ways how complex this particular statement is to get a synthetic data set which actually represents the real-world idiosyncrasies. Or in other words, this has actually been implemented in other information retrieval methodologies, but within health data, it is quite challenging. And when it comes to demographics, this to a certain extent can be achieved, for example, using kernel density estimators and differential privacy and etc. So this is an area which we could explore to start with, starting very similar to the initiatives of what Cynthia has done at the demographics level for creating a standard data set for patient matching. And then the next thing is understanding the quality of data, which is something I explained before, the completeness and standardization as key performance metrics, creating a minimum acceptable standard for matching algorithms. Then finally, we can think about promoting comparative effectiveness of these patient matching algorithms based on these different use cases. So by comparative effectiveness, what I'm trying to say here is the reproducibility of algorithms in a specific source versus cross-facility. So next slide, please. So how can we embrace the upcoming technology, such as machine learning and towards artificial intelligence in each one of these steps? For example, we can start thinking about hybrid framework or transfer learning approaches where we would actually start with assessing the quality of data to make intelligent decisions at the point of ingestion till the point of decision making throughout the complete data life cycle with constant monitoring of the data. And then we can also think about including external sources such as biometrics or Internet of Things, within the area of differential privacy to create an API ecosystem very similar to what the NIC project has done, Project Unify has done. So this is what I have, and thanks a lot for your time. And I would like to thank ONC to give me a chance to talk about this one.
Thank you so much, Suresh. So next, I would like to introduce Tom Meinert, a Senior Product Manager at Imprivata, and Nader Marabi, Executive Vice President and Vice Dean, Chief Digital and Information Officer of NYU Langone Health. Tom?
Hey, Carmen, can you see me?
Yes, yes, perfect.
All right, excellent. Thank you very much. Carmen, can you confirm if, there it is. There's Nader. How are you?
Can you guys hear me and see me?
Yes, perfect.
Okay.
All right, excellent. Thank you. Next slide, please. All right, so just a little introduction to Imprivata if you're not as familiar with us. So Imprivata is a digital identity solution provider focused exclusively in healthcare. And we're just north of Boston in Lexington, Massachusetts. We got our start on the provider side, thinking about clinicians, tap and go, sometimes we're known as single sign-on. But really about 10 years ago, we recognized the need to not only focus on the providers in healthcare, but the patients as well. Next slide, please. And so Patient Secure, we've been working on this problem with our customers, and that problem being positive patient identification and linking them to their medical records since 2008. We've worked with over 50 health systems across the United States. We have over 18 million patients enrolled and over 130,000 authentications done per day. Next slide, please. And just a little bit more about our work, more highlighting our customers. Our customers have been highlighted as well as our solutions across the industry, and really just trying to solve for that problem of matching and verifying patient identities and matching them to their medical records. Next slide, please. And just to give you a little idea of the breadth of our customers. So this is not everyone, but just to give you an idea. Our customers are across the country, from the East Coast to the West Coast, north to south. And it spans across both ambulatory care as well as acute care. Next slide, please. So in particular, COVID-19 for us has had a huge impact in healthcare, and we all know this. But it's really, when we think about this, it's the impact on patients. So patients now more than ever are interacting with multiple care teams across different devices, both mobile or a computer like the one that I'm sitting at now, as well from different areas. So traditionally we think of the urgent care clinics, the hospitals, but now, you know, we're thinking about being on the road or at home. I have an appointment next week and I have to check in for my appointment from the parking lot. And we start to talk to our customers and think about, well, how do you verify a patient's identity from these new workflows? But now more than ever, it really stresses that need for validating and verifying who the patient is that you're about to give care to, and ensuring that their data is accessible when you're giving that care. Next slide, please. And so at a core, you know, we truly believe that interoperability and efforts for interoperability requires that certainty of patient identity, that one identity across the continuum of healthcare, and that my identity and my data should follow me no matter where I go, from the hospital to the pharmacy or maybe sitting at home, just as easily as my financial identity and my data and my ability to pay for these services follows me today. Next slide, please. And this is really what drives our vision. So day in and day out, this is what we think about, is how we can solve that problem of patient identification to really improve interoperability for care. Next slide, please. So why biometrics? So we think about this in a few different dynamics. One is we think matching algorithms, no matter how good they are, they're only part of the equation. You can have one record for each patient, but you really need to be sure when Tom Meinert Sr. shows up that he's not being linked to Tom Meinert Jr.'s record. And we believe that biometrics and patient authentication is a safe, secure, and easy way to solve this problem, to easily verify the patient that is standing in front of you that you're about to give care to, and ensure that they're linked to their data, no matter where they are, no matter what sort of systems they may be using. Also, it provides near real-time usability and has applications for point of care. You want to be sure before I have a lab draw of who I am and who is that patient. Another thing we think about a lot is patient experience. So there's a very practical piece to this that no matter what the solution is when we talk about patient identity in healthcare and solving this for patient matching, it needs to be friendly for patients. It needs to be something that they're going to be able to use so that it's a very practical solution. And we've worked with our customers over the last 12 years, and we've interviewed patients. We've sat in the EDs, we've sat in the registration areas across the countries to ensure that this is a solution that is friendly and usable for patients, because at the end of the day, whatever the solution is, it needs to serve patients. Next slide, please. And really, we believe it's about getting it right from the start. So through proper identity proofing, assigning authenticators like a biometric to a patient, you're able to avoid these downstream consequences that we're trying to solve for. You can enhance that patient satisfaction. You can improve patient safety. You can support interoperability efforts, and you can really help drive those revenue efficiencies downstream as well. But it's all about getting it right from the start and ensuring that you know who that patient is up front. Next slide, please. And maybe 3 clicks here. This one builds. There we go. And so our role, as we see it, is verifying that patient identity from amongst the number of Toms that may exist, Tom Meinerts that may exist. And there's dozens of them just in my area. And then ensuring that when I come in, I'm linked to my medical record. Ensuring that they have safe, secure, and convenient access to their data as well. Next slide, please. So as I mentioned before, we've been working with our customers now for over 10 years. And at the core, what we were trying to solve 10 years ago is verifying who the patient is, being positive in their identity before I give that care and matching them to their data. And we believe now, especially in lieu of COVID-19 and the explosion of digital solutions, telehealth, patient self-service, that problem is now more valuable to solve than ever before. And that you really need to think not only about the future, so telehealth, but keep in mind that at some point I'm going to come in and see my physician. And so we want to make sure that we have a solution that spans both the physical and the digital world. Next slide, please. So some key takeaways. Patient matching does not stop when the records are matched. It's critical that we verify who that patient is in front of us and accurately match them to their records. Biometrics provide a very secure, consumer-friendly method to do that, and the patient is positively identified to their information. I would also say, as I mentioned before, patient experience is critical. We've spent a lot of time at Improbata talking to patients, observing patients, and trying to find something that not only works for our customers, but for patients as well, because adoption is key. We're really starting to think in the mind of consumer, because if we want something to work, we really have to get into the minds of ourselves as patients to make sure that it's something usable for them. Next slide, please. And now I'm going to hand it over to my colleague, Nader Marabi, to talk a little bit more about the practical experience. NYU has been using biometrics for 10 years now, and I think they can really speak a lot to their experiences in this.
Great. Thank you, Tom. Thank you for having me in this panel. I don't have any slides, but you guys don't have to look at my picture for the rest of 10 minutes I have. Thank you. Okay, so patient identification, it's not a new problem. Even before tech, it was an issue about finding the right paper chart, and when it comes to tech IT to become also a complicated issue, and it's been around for some time. So all of you know, it drives the rest of the care about safe care, and you want to make sure that you get it right, and patients do get hurt across the United States by mismatching identity. So our institution, when we were putting an electronic health record back 10 years ago, institution-wide, our motto from our leadership was one patient, one chart across the health system. And we kind of stuck with that motto throughout the 10 years and continue to do so. And also the new emphasis on digital health and is about really how do you identify who you're going to treat safely and then and do business with, and really highlights the importance of identity management. Also, has been costly. We still, have staff who really look at review, close matches. If we, there's an accuracy factor. If we don't have the, highest level of confidence, it goes to a human queue to review a identity matching and make sure it's the right patient. So it is costly. There's a whole health information management department dedicated to do proper identity matching when the system cannot for sure figure out is the right or the same patient. So we've been and then it's really how do you the simple technologies that you need to deploy to do the proper matching, both in the back end and the front end, is a compilation of technologies that we deploy to make this happen. And then back into care processes where you have to print the right wristband, and then how do you secure and teach staff to, when you give medication, to match the patient wristband with the right medication, and then the right caregiver giving the time. That's the electronic health record does that. We've been at it for quite some time and does that very well, I think, when it's followed. But the biometrics are important aspects of really identity proofing. Again, it avoids medical errors. Also, make sure that avoids falsification of insurance cards. And we actually, biometrics, by that mean we have to deploy not only the palm vein technology, but also getting the records of picture photo. Because I think these two combination actually helped us to really identify a patient, both visually for providers and through the process of registration securely. And I'll talk about the digital where patients come in through telehealth. Use telehealth sessions, again, quite complex. But we've been deploying this technology that Tom mentioned for past 10 years. Obviously, it's a new technology. In 2009, 2010, we had to work the kinks through, but it's working fairly well for the past 8 years in our health system, and it's across the house. So every person who comes matriculate, put their palms, and they get scanned. The nice thing about palm scanning is not intrusive. It's not an iris scan, or people don't want to have something shown in their on their eyes, or patients don't like fingerprints because that has a law connotation. So we thought this was most the safest way, and it also doesn't. It only stores a blood flow underneath palm of your vein. So it's a very it's just a number algorithm. Doesn't take a picture of your palm. It's just measure the blood flow. But as we moved on through the spectrum of digital health, it is still becoming challenging to make sure that if someone, for example, we do 100,000 online appointments a month. As patients go and book appointments online, how do we make sure securely that's the right patient? So there's a whole process to do that, and still there's a costly where the algorithms are not that great, still not as sophisticated to match, and so we have to. Some of them do go to human queue to make sure that we match them. But it's and also telehealth as we do virtual visits, especially during COVID. Between March and now, we've done over 500,000 virtual visits across our health system, and a lot of required patients to matriculate on their own to book the visit, and we to use disease matching. So again, it raises the bar higher for us to validate who it is, who we're treating, and then we not sure put it on the queue for manual staff to resolve, and to make sure that we're taking care of the right patient, the right appointment. What do we need in terms of how do we make the I think the technology can get better. The algorithm should be much more sophisticated. I think we think technologically, linking IDs is kind of interesting concept, but that has a lot of privacy issue concerns. Having one national ID number, I'm not sure ever going to happen, but how do we link within our health system? Clearly, we have one patient, one chart motto, but how do you then match across when you want to pull patients' records from regional information exchanges? They're not quite perfect yet. They sort of work when you have the right level of data, but there are other things that you can do. So the technology is there, but they can improve. The algorithm should get more sophisticated. And then we have to put a lot of safeguard security, as we are doing around patient records, of course, and then identity proofing. Also, third-party data is helpful as we use products such as LexisNexis and others to really match the right patient. And also, as patients move around and change their addresses, we kind of continue to keep track of that so that we can securely match them. So. Also, we have to make sure that we are mindful of the regulation. How do we apply regulation in a more mindful way, but in more way to help the patient and get their experience better, as Tom touched base. So I think identity, not having probably a matched identity can be very also frustrating for a patient if we can't recognize them and securely match them quickly for them to book an appointment or get to the physician quickly. So that's something that we can we can improve on. So I'll stop there.
Carmen, I think you're muted.
Thank you for telling me. We're excited to introduce Jennifer Stoll, who is next. Thank you so much, in our agenda block. She is Executive Vice President in Government Relations and Public Affairs at OCHIN. Hi, Jennifer.
Hi, Carmen, and hello, and thank you to the ONC for the opportunity for me to share the OCHIN journey on patient identity and matching in underserved populations across the country. As Carmen said, I'm Jen Stoll. I lead government relations and public affairs for us. And what I wanted to do is take a couple of minutes just to introduce you to us if you're not familiar who OCHIN is. And again, a little share of the experience that we've had in looking at our own data and the work that we're doing to support underserved communities, including 26 public health departments and hundreds of FQHCs across the country look at this issue. So if you could go to the next slide, please. So just a little bit about OCHIN. We have been around for 20 years. We are a leading edge health IT service provider with a national network of about 500 healthcare organizations across the country we touch. We make sure that technology isn't a barrier to high quality healthcare. We work with more than 20,000 providers across 47 states to ensure they have access to technical support and a wide range of EMR, telehealth, broadband services, as well as data-driven practices. Our network of health centers and providers serve more than 5 million patients. And you can see from this slide the racial, ethnic diversity and the social complexity of the patients that we work with. There are about 57,000 homeless patients that are in our system. A vast majority of those that are being served in health centers that OCHIN works with are under at or below federal poverty level. When you look at up to 200% of FPL, it substantially increases up to about 86% of the population. Also looking at other vulnerable populations, women, children, communities of color. And so part of our work is to ensure that we help health centers capture data at the point of care, and patient records and duplications is definitely something that we are very cognizant about. We help them by making sure that the data is entered correctly. We also have hands-on help through the Health Center Controlled Network Award that we received from HRSA. We're the largest HCCN in the country, to be able to provide that technical support, even in the health center with embedded staff, to be able to make sure the data is collected correctly at the right time. And so we've been very, very passionate around making sure that data collection is accurate, and that we also ensure staff are trained on how to collect it. One of the challenges we face in the health center world, though, is turnover of staff. I'm sure many organizations experience it. It's magnified in the health center world. So consistently training staff so that they understand the workflows and they're capturing things correctly is super important. And so we've been advocating for more standardization around HIT standards and improving the capture of data. But what was really stunning to us is when we looked at our actual data around patient matching, how it's really become an issue of equity. And let me explain what we're seeing with the next slide, please. So we went through this journey where we pulled our own data, and we were really quite surprised at what we found. One of the things that health centers have to do is collect UDS, Uniform Data Standards, to be able to achieve their HRSA metrics. And so what makes this very different is that race and ethnicity is collected with every patient that's seen. And what we saw was pretty startling to us, is that, you know, Hispanic patients make up 21% of the population that we serve, and yet they make up 35% of the duplicates. You can see that also in pediatric patients, which was really interesting, is children under 19 represent 22% of our population, but make up 35% of duplicates. And so as we're thinking about times of disparity during COVID crisis, we see this as an issue that magnifies the COVID crisis, as we already know that communities of color are disproportionately impacted by COVID, and adding patient mismatching and duplicates only magnifies this problem. So next slide, please. So this is showing the data graphically on our journey so that you can take a look at this in the future. You can go to the next slide. So we view this, OCHIN views this as improvement in patient matching. It is a significant way to reduce health disparities. Specifically to every mismatch or duplication of a patient record puts two patients at risk, the person receiving care and the person who has been inaccurately matched with this patient. Because we work in 47 states and we have so many different ways that patients can be matched through their local HIEs, it even is magnified by having many different ways to connect into matching patients. Population that OCHIN serves and patient matching and duplicate records have been, our patient population definitely has a double burden as a result, and we truly believe this is something that could be solved. We also believe that for accurate vaccine records to be vital, not only for managing the dissemination of a COVID vaccine when that comes, but catching up for families or other standard childhood vaccines that they may be put off. So thinking about immunizations, both COVID and beyond. We're already seeing right now significant declines in vaccination rates in health centers across the country. It's going to be magnified again. How do we help patients continue to get the care that they need in the right setting? And if we don't get this right, it poses a long-term population challenge. I know everybody on this call or on the webinar understand this issue. Our health centers are actually living this every day. We look at the resources that our teams are implementing to be able to overcome this challenge, but it's almost fighting it with one hand behind our back. This is something we can solve as a country. And if this is increasing inequities and disparities across the country, we need to create a sense of urgency now to fix this problem. So I think I cruised right through this talk, but I am always happy to answer any questions, Carmen, and happy to also be emailed if you want to go to the next slide. Then my email is on this slide, and if there's anybody who has any questions, I know Tom presented some of the OCHIN data earlier in the morning, but if I can ever be helpful, I am here, and we just want to improve the health of the country.
Thank you so much, Jennifer. That was an excellent presentation. Thank you to all of the presenters who presented throughout the day for a day-long session. To provide some closing remarks, there he is, Steve Posnack, our Deputy National Coordinator. Steve?
All right, thanks, Carmen. I can tell that I am getting picked up by the microphone, so thanks very much. It's a good thing I got out of hair and makeup early, so I was ready to jump in since we were going a little bit quick today at the end. First, I just wanted to say thank you to everybody that's attended, to our team at ONC. Special thanks to Carmen, who is slowly becoming a deputy MC for these types of events that I often have to do as well. To all our presenters, thank you very much. Today was our final public session after doing one in June, July, and the end of this month. I don't know what kind of compression algorithm we used today, but it was jam-packed. I attended as much as I could, schedule permitting, and we covered so much ground. So there is probably a full day's session in each of the topic blocks that we created and that your colleagues spoke to today. From the morning, where we talked about privacy and security policy considerations and trust frameworks and coalitions, to this afternoon, where we talked about tech and governance, innovation, and equity right at the end, which is critically important for the work that we do to work for everybody in the country. Not only did we get an update on what's going on across the industry, we got an update on how different technologies are being used and who's using them, right? So a little bit of the what's going on inside, down in the trench. Today highlighted yet again the many dimensions for which we need to account when it comes to identity and patient matching and record linking, aggregation, and the like. When it comes to identity, not just for healthcare, and how the technologies and policies need to align, though I think we got a few sprinkles of, it's not a technology problem anymore. There are certainly areas where we have an opportunity to continue to refine the technology and make the user experience better, even if some of the policy sides and organizational business practices need to catch up and align. So in some respects, there is so much going on, and per the earlier sessions, it may feel like it's been going on for an eternity. I think it's easy to say that the work that we're doing is really forward momentum and progress toward what has been perceived or as represented as an intractable problem. We actually see that we're making a good deal of progress, but there's still a lot of work to be done and alignment to be had across different industry groups and consensus organizations and the like. So what you heard and what we saw today is that there are groups perhaps more rapidly chipping away at these different parts of the tough problem. And this requires a concerted effort industry-wide, not that one particular group is going to solve this problem alone, which really made me think about a concert. Having been a band geek, fun fact, in the earlier part of my academic career, tenor saxophone, if you must ask. We have to, either as band or orchestra, you're really blending all of the different work and musical notes together. And it's really that blending as your national coordinator's office that we are looking to maximize. So when it comes to the work overall in this area, like you, we are looking to see increased competition. We're looking to see increased innovation. We're looking to see increased simplicity, again, both for providers that are using systems every day, for us as patients that are interacting with the broader healthcare economy and e-commerce aspects of healthcare. And we are looking to see where activities like the ones that were discussed today are converging and aligning around a shared center. And there may be different shared centers for different parts of this problem or different parts of this problem space as a whole, but looking to see again that these vectors are coming together toward a shared point of consensus and alignment. And so when you're looking across who is seeking to a certain identity and the community in which they live, whether or not they have certain credentials or other types of attributes that they can represent to an identity provider. That is an important factor. The data quality that was referenced, whether or not we're looking to compare or reconcile identities within a domain or across domains, the kind of different layers at which we're operating. It's almost like a three-dimensional chess kind of question in some cases. And what kind of governance and policy surround exists for the work that we have overall. So in closing, there's always an element of this, what can you do? And I hope you got a sense of the overall momentum, but also a renewed sense of urgency to keep on doing the work that you do. Know that we appreciate your work at ONC, and we'll continue to work to help coordinate it, and then to keep driving forward. So if it's an opportunity to participate in one of the consortia that you heard about today, some of the standards development organizations, some of the technical work that's going on, technical solutions. If your organization is in a position to pilot something and then share those results, those are all things that you can do to help advance these activities and the cause as a whole. The one other thing I would mention, which has been represented a few different times at the break, because this is our last public session, we have another opportunity for public comment. And if you can believe it, today is the last day of August. This Friday, September 4th, will be a deadline for submitting public comment again, identity.onc@hhs.gov. And with that, I appreciate the opportunity to give you some closing remarks, giving you a little pep in your step there to keep on going. And very much, again, appreciate the time and opportunity that all of you have dedicated and spent with us and with your colleagues throughout these sessions, and look forward to continuing to work with you in the future. Back over to you, Carmen.
Thank you so much. That is excellent, excellent way. Thank you also to the patient identity and matching team at ONC, Dr. Andy Gettinger, who opened up our day, Beth Quill and Lana Moriarty, and of course to Steve Posner. Thanks, guys. We hope you found it informative and educational, and you will tune back in to all of our future ones.